Next phase of the cardiac cycle. What happens? Now your ventricle starts to contract, and what happens when the ventricle contracts? The first thing that it will do when the ventricle starts to contract, what happens? AV valve will close. AV valve will close. AV valve will close. Yes or no? So producing which sound? Producing S1. Okay. So let me draw a line signifying your cardiac cycle. This is the line I am drawing. So this was the phase of atrial systole. So from here onward your ventricle started contracting. So the first sound that came was S1. Okay. Now ultimately ventricle will keep on contracting till it opens the one of the aortic or pulmonary valve, till it opens aortic or pulmonary valve. So till that time ventricle will keep on contracting, increasing its pressure, so that this phase is known as isovolumic contraction. You all know isovolumic contraction. Okay. So when the aortic valve opens, let's suppose in the end of isovolumic contraction your aortic valve opens. Opening of aortic valve produces which sound? Opening of aortic valve produces which sound? Ejection click. Absolutely right. So that Bilaspur has got the answer. It is the ejection click that is heard. Okay. So from the ejection click, your ejection period starts. Blood goes out from the ventricle and your ejection period starts. This is your ejection period. Okay, you have understood. So now after the ejection, what will happen? Ventricle will start to dilate or relax. Yes, ventricle will start to relax, and AV valves are already closed. AV valves are closed, but when it starts to relax, the moment the ventricle starts to relax, the pressure in the LV or RV decreases. The moment pressure decreases, which valve will close? Aortic valve will close. Aortic valve and pulmonary valve will close, producing which sound? Closure of the aortic or pulmonary valve produces S2. Okay. So now you have an S2, after which isovolumic relaxation is going on. So pressures keep decreasing in the ventricle because of isovolumic relaxation, till what happens? Till AV valve opens. So in the end what happens? AV valve opens. So your AV valve opens. In the AV valve opens. So the opening of AV valve produces which sound? Opening snap. Absolutely right. Opening snap. So in the end of isovolumic relaxation, you hear opening snap. Okay. So after the opening snap means after the AV valves open, what will happen to the blood in the atria? It will start to flow towards the ventricle. Okay. This movement of blood from atria to ventricle, it is passive movement. There is no chamber is contracting. It is only or both the chambers are relaxed, but pressure in atria is high, so blood goes from high pressure to low pressure during this filling, and this filling is known as passive filling. So passive filling, when the blood goes from atria to ventricle during passive filling, absolutely right. So most of you have already described which sound will be produced. S3 is produced. Okay, so you have S3 being produced during your passive filling. Okay, another MCQ comes from your cardiac cycle, basic cycle, that passive filling results in how much filling of ventricle? It fills how much of ventricle? It fills around 70%, 70 to 75%, it's right. 70 to 75% of the ventricle. Okay, see, it's very simple. Just you remember that once the AV valve opens, your blood in the atria being at high pressure, it will move towards the ventricle, and therefore this is a passive filling. Okay, and that is what is known as passive filling. And now what will happen as the blood leaves the atria? What will happen to the atrial pressure as the blood leaves atria? Atria empties, so atrial pressure decreases. What will happen to the pressure in the ventricle because of the ventricular filling? Ventricle pressure increases. Yes or no? So what will happen? Both the pressure, they become equal, and now there will be no flow of blood, and this phase in the diastole where there is no flow of blood is known as diastasis. Stasis. Diastasis. Diastasis. Now, after diastasis, LV is only filled 70 to 75%. So where will 20 to 25%, from where will it come? It will come because of the atrial contraction. Now atria will contract and push the blood. So again the cycle will start. This is active filling. So active filling contributes around 20 to 25% of the filling. Okay. So this is your cardiac cycle, and now you have realized what are the sounds are produced at different intervals, and these sounds and how they are produced. Any confusion? Okay, I'll just quickly revise you this thing because few of you have not understood. See, atrial systole, atria contracts, pushes the blood into the ventricle, resulting in an active filling producing S4. After that, the ventricle starts to relax. After that, ventricle starts to contract. This is known as isovolumic contraction. During isovolumic contraction phase, the first thing to happen is, because of the increase in the ventricle pressure, the AV valve closes first, producing S1. So beginning of IVC or isovolumic contraction, you hear S1. Now ventricle pressure keeps on increasing till it becomes more than the aortic pressure. Aortic diastolic pressure, you all know it is 80. So we have to go beyond 80 to open the aortic valve. So therefore ventricle has to contract more to open the aortic valve. So isovolumic contraction continues till aortic valve opens. The moment aortic valve opens, that produces which sound? Ejection click. So after ejection click, the ejection of the blood occurs and blood goes into the systemic or pulmonary circulation. After the blood has gone, now ventricle starts to relax. So the first thing is, see the systolic pressure of the ventricle when it contracted, when ejection was going on. What was the systolic pressure of the ventricle? Yes, anybody? What was the systolic pressure of the ventricle at that time? When ventricle was contracting and ejecting the blood? Yes, 120. 120 was the pressure of the LV. So when LV has to open the AV valve, that means LV pressure has to be lower than the LA pressure. What is the mean LA pressure that you know? I told you mean LA pressure is 4 to 12. 4 to 12 means 8 average. 4 to 12. Okay, so that is the mean LA pressure. So LV pressure has to come below the LA pressure to open the AV valve. Okay, so that means LV pressure has to come down below the LA pressure to open the AV valve. So ventricle starts to relax. The moment ventricle starts to relax, the first thing to happen is aortic valve closes, producing S2. But relaxation continues. Why? Because ventricle pressure has to go down below the LA pressure. So once the ventricle pressure is below LA pressure, AV valve opens, producing an opening snap, and the blood in the atria starts to move into the ventricle, and this is the passive filling producing S3. So once the filling of ventricle occurs, the pressure in ventricle increases and atrial pressure decreases because of the atrial emptying, and this phase is known as diastasis, when the two becomes equal. Okay, so you have understood the cardiac cycle and the different sounds. Let's move on further. I'll tell you important point regarding the few of these points regarding ejection click. Let's talk about clicks. What are the different type of clicks? What are the MCQs that are asked on click? See, click is, there are two types of clicks. Okay, you can classify them as right sided or left sided. Okay, so right sided click or left sided click. Let's talk about further. Right sided click, when we talk about click, there are two types, two ways the click can be produced. One is because of the valve opening, aortic valve opening, pulmonary valve opening, that can result in a click. Okay, the other click is that it may not come from the valve. Valve is normal, but from where the click is coming from the great artery. What happens? See, you can see my hands. So what happens is your aorta is like this before the blood goes into aorta during systole. So what will happen? When the blood suddenly goes into aorta during systole, aorta dilates. The moment it dilates, so it will produce some sound because of the dilatation, that is known as vascular click. So you have two types of click, one is valvular, other is vascular. So similarly, left sided also you have valvular and vascular click. Okay, what are the causes of these clicks? That is what comes as the MCQ. Valvular click is always seen in stenosis. So in right side it would be pulmonary stenosis. And on the left side valvular click would be aortic stenosis, but not all causes of aortic stenosis, only bicuspid aortic valve. Bicuspid aortic valve is used for the, it causes the valvular click. Okay, next, vascular click. Pulmonary artery causes the vascular click on the right side, and the etiology is, what is the etiology? Eisenmenger syndrome. Eisenmenger syndrome. Okay, and vascular click on the left side. What is the cause of vascular click on the left side? It is TOF, tetralogy of Fallot. In the TOF, what happens? Because of the overriding of aorta and because of the large VSD, even RV blood goes into the aorta. So large amount of blood goes into aorta, resulting in vascular click. Okay, all this comes as an MCQ. Right vascular cause, Eisenmenger syndrome. Eisenmenger syndrome. Okay, so another important point for this, right sided click, whether it is vascular or valvular, right sided click, they increases on expiration and decreases on inspiration. So that means, what does that mean? See, just tell you one thing, that whenever your blood volume increases in your heart, your sounds increases, murmurs increases. So preload, if you increase the preload on the heart, your murmurs and your sounds will increase. Okay, so on the right side, if we talk about the right side, if you have to increase the preload, which phase of the respiration you have more preload? Inspiration, absolutely right. So inspiration is the phase when you have your more preload. So all your sounds, all your murmurs, they increase with inspiration on right side. But click is the only exception that decreases on inspiration. You are getting the point? So all sounds and murmurs on right side increases on inspiration, but only exception is your click. Okay, so only exception is your click, which decreases on inspiration. Now, whereas left-sided click, not affected by respiration, not affected by respiration. So it is not affected by respiration, left-sided clicks. Okay, so another way of describing them is that right-sided clicks are also known as phasic click. Why they are known as phasic click? Because they are better audible during which phase of the respiration? They are better audible during which phase of respiration? They are better audible during expiration. Okay, so they are known as phasic click. Whereas left-sided clicks, they are not affected by respiration, so they are known as non-phasic. So the question comes is, TOF has what type of click? What is the click in TOF? So TOF has non-phasic vascular click. Non-phasic vascular click. Okay, that is the complete answer. Okay, let's move on further. That is all about the clicks. Okay, S3, I'll discuss about something about S3, and that is we had seen during the passive filling S3. See, before I go on to S3, let me discuss with you the JVP, and then we will move on, because I need this cardiac cycle diagram with me to explain you the JVP. Okay, let's move on to JVP. First understand JVP, then I'll tell you about S3. Okay, so now when I talk about JVP, exception point is that right sided click is the only sound on the right side that decreases on inspiration. Okay, so next is, what is the JVP? See, JVP is nothing but that you see the different pulses or different waves in the internal jugular vein. Okay, so these internal jugular vein, that the waves that you see, from where do they come? Do you have a pulsatile flow in the vein? So they come from chamber, that is RA. So in vein there is no pulsatile flow. So first MCQ that I want to cover here is that what is the condition where JVP would be increased but there would be no pulsation. So that means no pulsation means that this JVP is not in connection with the atrium. So that means if it is not in connection with atrium, so there is no pulsation, but venous return is not happening, so you will have SVC obstruction. Absolutely right. SVC obstruction is the answer for this. Okay. So next, let's move on further. Now, if you have to understand JVP, see, the very important concept is that JVP is all about RA pressure. It is not related to ventricular pressure. So don't think about ventricle when I am talking about JVP. Okay, only consider atrial pressure changes during cardiac cycle. So that will tell you about the JVP. Okay, let me explain you. First part of cardiac cycle, atrial systole, it's already drawn down. So during atrial systole, your atria contracts. So what will happen when the atria contracts? Your atrial pressure increases. Yes or no? So atrial pressure increases means JVP will have increase in JVP. So your JVP will be increased. So this ascent, this is the ascent that occurs because of the atrial contraction. So this is known as which wave in JVP? A wave. Absolutely right. This is an A wave in JVP, and this is because of the atrial contraction. Okay. After this, atria starts to relax. So atrial pressure, what will happen to the atrial pressure? It will start to fall down. Okay. So atrial pressure starts to fall down. So what happens? After this, second phase of cardiac cycle, ventricle contracts. So RV and LV, they both contract. So what will happen with the contraction of the RV and LV? The AV valve gets closed. Yes or no? So the production of which sound? Production of S1 would be there. Okay. So AV valve closes, produces S1. Okay. Now ventricle continues to contract. This is isovolmic contraction is still going on even after the S1, it still continues. So during this time, what will happen? This blood in the ventricle, that is in the right ventricle, the blood, it pushes the AV valve towards the atrium. When it pushes the AV valve towards the atrium, there is a small increase in the atrial pressure, and this small increase in atrial pressure results in increase in atrial JVP pressure, and this wave is known as C wave. Okay, any doubt about it? Okay, so let's move on further. So the first MCQ, S1 comes before which wave? It comes before C wave. Okay, so now let's move on further. Now after the C wave, what will happen? This ventricle will open the pulmonary valve. Pulmonary valve gets opened, and the blood that was pushing the AV valve, what will happen to this blood who was pushing the AV valve? This blood will go into great vessels. This will go into pulmonary artery. So now the push on the AV valve is gone. So what will happen to the AV valve? AV valve will come back to its normal position. AV valve will come back to its normal position, so resulting in decrease in the atrial pressure. Okay, so you have a decrease in the atrial pressure once the ejection period starts. Okay, so you have over here your this total descent starting from the A tip to the this point, this we call as X descent. And so X descent basically has two components, if you can see. One is before C wave, one is after C wave. Yes or no? So before C and after C total is X descent, but after C wave we call it as X prime. So many of your books says X prime. Okay, but it does not differentiate whether it is the same X descent or different thing. So X prime is the second component of the X descent. That is the X prime. Okay, understood. So let's move on further. Now whenever see atria, if you see the atria, what is happening in the atria? Atria is currently relaxed, yes or no? So atria is relaxed at this moment. So, and the pressures are low. Atria is relaxed. So what will happen to the venous return? Venous return will start to happen, and atria will start to fill with the blood. So slowly atria starts filling with the blood, and atrial pressure starts to rise. Yes, so atrial pressure keep on rising, so your JVP pressure will also rise. Okay, so this is what is this is happening because of the atrial filling. This is happening because of atrial filling. Okay, see, do not think about ventricle. We are just talking about atria. So atrial filling is happening, that results in a increase in the atrial pressure, slow increase in the atrial pressure, and that increase in atrial pressure is known as which wave? V wave. This is known as V wave. Okay. So now what will happen? Atria will keep on filling till what part of the cardiac cycle it will keep on filling? It will keep on filling as long as LA, as long as RA pressure is RA pressure will keep on increasing because of the filling, as long as the blood in the RA is increasing in volume. Yes or no? So pressure in RA will keep on increasing. But the moment AV valve opens, that is your this phase, the moment AV valve opens, what will happen to the blood in the atria? It starts to flow towards the ventricle. So the moment it starts to flow into the ventricle, what will happen? Atrial pressure will drop down. Okay, so this is known as Y descent. So AV outflow occurs, you are right, absolutely right. AV outflow occurs, and the blood goes from atria to ventricle, atria gets emptied and atrial pressure drops down, and that is what is Y descent. So what is happening event at this point? From where the where the pressure in the atria starts to drop, that means what is happening? Which sound is there at that point? Opening of AV valve. Which sound? Opening snap. So after opening snap, your atrial pressure starts to drop down. Why? Because the blood from atria goes to ventricle. Okay, next. During this passive filling, when the blood is going into the ventricle during Y descent, which sound will be there? Which sound? S3. S3 would be there, not S4, S3 would be there. This is passive filling. Blood is going from atria to ventricle passively. Okay, so this is your S3, and after that again what will happen? What will happen? Because atrial pressure has dropped down, atria is still relaxing, atrial pressure again drops down. So what will start? Atrial filling will start and atrial pressure increases gradually, and this is what is known as H wave. This is known as H wave. This is known as H wave. Again, because atria starts to fill with blood because of the venous return. And when in the end, again atria will contract, resulting in which wave? A wave. So the cycle will again start. Atria again contracts, cycle will again start. So contraction of atria produces which sound? So along with A will go back, along with A, this over here, which sound is produced? S4. So is that clear to you? So things are clear to you. So how the JVP is? So we'll move forward. If you have understood this concept, where is S4, where is S1, where is opening snap, where is S3, then okay, tell me, where do you think will be your S2? Where do you think will be your S2? Where do you think will be your S2? See, at the peak of V wave, you have your opening snap, and so S2 has to be before that peak of V wave, yes or no? So it has to be before the V wave, yes? So somewhere between X descent and V wave, you will have your S2. So that is, you are right. So somewhere over here, you will have S2. Okay. So I think it's already overcrowded the page. I just wanted to draw in this page because I wanted to correlate with your cardiac cycle. H wave is nothing but after Y descent, you have an H wave because of the atrial filling. Whenever atrial pressure drops down, atrial filling occurs, and that results in H wave. Okay, so let's move on further. You will better understand JVP now when I discuss with you abnormal JVP. Abnormal JVP. Okay, so S2 is after X descent. Yes, you are right. S2 has to be after X descent and before V wave. So the question that comes is S1 and S2, when do they occur? S1 occurs before C wave, S2 occurs before V wave. That is the MCQ we have to cover. So that you have understood, I think. So now let's move on further. What is the abnormal JVP? You will better understand now. Okay, so see, when let me talk about tricuspid stenosis. What is the abnormality in the JVP? Tell me, what would be the abnormality in JVP? in tricuspid stenosis? Just think of it. Which wave will be affected, which wave will not be affected. So, okay, see what is happening is in tricuspid stenosis, blood is not going from atria to ventricle properly. Yes or no? There is a problem over here. There is an obstruction over here. So, what will happen? Yes, what will happen? Both passive filling and active filling will have resistance. So, what will happen? Passive filling means which wave? Which wave in JVP? Passive filling means which wave in JVP? Passive filling means which wave in JVP? Okay, so that means you have not understood. Okay, so let me explain you again. See, I'll describe the JVP once again. So this is your A wave because atria contracts, atrial pressure increases. Therefore, A wave, there is an increase in pressure in the JVP also. So you say A wave. Okay, after atrial contraction, atria starts to relax, so its pressure decreases. Okay, now meanwhile ventricle contraction starts, so it will close the AV valve first, that is S1. After that AV valve gets pushed into the atria because blood is there in the ventricle, that is pushing the AV valve towards the atria. Okay, so this results in C wave, small increase in atrial pressure, C wave. Now, once the pulmonary valve opens and the blood in the ventricle goes from ventricle to the pulmonary artery, what will happen to the pressure on the AV valve that was being exerted by the blood? That pressure decreases. As the pressure decreases, the AV valve being pushed, it settles down. It settles down and the pressure in the atria decreases again. So this total is known as X descent. Okay, so now what will happen? Whenever atrial pressure drops down, venous return starts and atria starts to fill. As the atria starts to fill, atrial pressure increases. So this increase is known as V wave. Okay, now after this, after the V wave, AV valve will open. AV valve will open producing opening snap. The moment AV valve opens, the blood in the atria goes down to ventricle. Very rapidly it goes down to ventricle. So the moment blood goes down to ventricle, what happens to the pressure in the atria? Pressure in the atria drops down. So this is known as Y descent. So pressure in the atria drops down and this is what is known as Y descent. So that means this Y descent is happening because of which filling, active filling or passive filling? Passive filling. Yes or no? So Jammu, you have realized this is the passive filling that is happening. So your passive filling is resulting into your Y descent because passive filling blood is going from atria to ventricle and that results into decrease in the atrial pressure and that is what is Y descent. Okay, so once the Y descent occurs, that means which sound is produced over here? S3. Okay, so now you tell me in tricuspid stenosis, what will happen? Will the blood go from atria to ventricle during passive filling very rapidly or it will go very slowly? It will go slowly. Yes or no? So if it goes slowly, so what will happen to the decrease in the atrial pressure? It will occur rapidly or it will occur slowly? Decrease in atrial pressure. Decrease in atrial pressure will occur slowly. So what will happen to the Y descent? Y descent would be sharp descent or it will decrease. Y descent will decrease. Less steep. Y descent will decrease. So that is the answer for tricuspid stenosis. Okay, your Y descent decreases. Okay. So now what will happen is Okay, let me finish off the JVP. After the atrial pressure drops down because of the passive filling, that is, passive filling means the blood has gone from atria to ventricle, so atrial pressure has come down. So now atria will again start to receive venous return and atrial pressure will slowly increase, and this is known as H wave because of the atrial filling. And ultimately what will happen? Atria will again contract and push the blood into the ventricle. So during tricuspid stenosis, again there would be resistance to active filling, so atria has to generate more pressure, so A wave would increase. So during tricuspid stenosis, what is the answer? Increase in A wave, decrease in Y descent. Okay, now if you have understood the JVP, now tell me TR. What will happen with TR? Tricuspid regurgitation, is it occurring during diastole or is it occurring during systole? So the during TR, your it is happening during systole. So what is happening during systole? See, normally what happens when the ventricle contracts, it pushes the AV wall towards the towards the atria, resulting in increase in atrial pressure. Yes or no? This we call as C wave. This we call as C wave. Now what will happen? Not only the wall will be pushed upward, along with the wall, what is going inside the atria because of the ventricle contraction? What is going into the atria along with the wall? Blood is also going into the atria. So that will result in more increase in the atrial pressure, and that will result in more prominent increased C wave. Large C wave. Okay. So now what will happen is, if it is a mild TR, then the blood will stop going into, more blood will not go into your atria, and your atrial pressure will come down just like just like a normal situation. So you will have a X descent. But X descent, it will not be, it will be reduced X descent. Yes. Now, if there is a moderate TR or if there is a severe TR, what will happen? After the C wave also, the blood will keep going into atria from the ventricle during the systole. So what will happen to the X descent further? What will happen to X descent? Atrial pressure will keep on increasing because blood is coming from ventricle to the atria and not decrease. So that is what happens is X descent will keep on decreasing, it may become flat, and ultimately it may increase, pressure may increase, and there will be only a single increase in wave, that is we call it as CV waveform. There is no X descent at all, and there is a common wave, that is CV waveform. Absent X descent, and you will form a CV waveform depending on the severity of TR. So X descent decreases, first thing, it will keep on decreasing, and if there is a severe TR, you may have absent X descent. Instead of that, you will have a continuous increase in atrial pressure, and that is known as merging of CV. So this is what is known as CV waveform. So throughout the systole, your pressure in atria will keep on increasing, and this is CV waveform. And the moment AV valve will open, this whole blood that had come during TR into the atria, this whole blood will come down into the ventricle very rapidly. So what will happen to the Y descent? What will happen to the Y descent? Y descent becomes very steep. Very steep, deep, sharp Y descent. Okay, so that is all about TR because that comes as an MCQ. Okay, now let's talk about Cannon wave. See, not all increase in A waves are known as Cannon wave. Not all increased A waves are known as Cannon wave. Cannon wave is a special term used when atria is contracting against the closed AV valve. Why the AV valve is closed? Because atria and ventricle, if they both simultaneously contract, no, not mitral stenosis. If both simultaneously contract, A is also contracting and V is also contracting, what will happen? Yes, both are simultaneously contracting. What will happen? There would be AV valve would be closed and atria would be contracting against the closed AV valve, resulting in the whole blood not going towards ventricle but regurgitating back into the JVP, resulting in tall JVP, that is Cannon wave, and we discussed yesterday complete heart block, one of the causes. Okay, so complete heart block is one of the causes of AV dissociation. Another cause is ventricular tachycardia. Ventricular tachycardia. And ventricular tachycardia, the another cause is, yes, Mysore has been talking about junctional rhythm right from yesterday. So let me reduce their anxiety. So what is junctional rhythm is, see, in the conduction system, you have a sinus node, AV node, bundle of phase, right bundle and the left bundle. Okay, this I again revise you. Okay, so what happens is, normally your conduction occurs from atria to ventricle. Is it sequential or is it simultaneous? I want to introduce these two terms. The activation of atria and ventricle, they are sequential or simultaneous? They are sequential. That means first atria contracts, after some time ventricle contracts. That is sequential. Okay, not simultaneous. How can it be simultaneous? There is a gap. First atria contracts, then there is a gap, that is the AV nodal conduction is slow, therefore it takes time, and then, yeah, nodal delay, absolutely right. So then you have a ventricle contraction. So now if you have a junctional rhythm, let's talk about junctional rhythm. Junctional rhythm means a rhythm that starts from the junction. Junction is your bundle of his, let's suppose. Okay, so if it is your junctional rhythm starting from bundle of phase, so wave of depolarization will go up also and will go down also. So what do you think? What would be your atrial ventricle relationship now? Sequential or simultaneous? Simultaneous. Therefore, you will have what is known as Cannon wave. You will have Cannon wave. You have understood? So junctional rhythm will result in Cannon wave. And it is not AV dissociation. There is no AV dissociation over here. It will not be AV dissociation. It will be AV is associated. Why AV is associated? Why? Because from the same point, both are resulting. Atrial depolarization also, ventricle. So there is a relation. Whenever atria comes, ventricle also comes. AV dissociation means the source of atria and ventricle both are different. Just like escape rhythm. Atrial source is sinus, ventricle source is your within the ventricle, that is escape rhythm. So that is what is known as AV dissociation. So this will not be AV dissociation. Okay, this is just a junctional rhythm. Junctional rhythm does not come under AV dissociation. You are getting my point. AV dissociation occurs when atria has its own rate, ventricle has its own rate. During complete heart block we did that atrial rate is the sinus rate, that is around 60-70, let's suppose, normal. But that is not going into ventricle, so we had a ventricle escape rhythm with a rate of around 30, 35, 40, right? So that means ventricle rate is 40, atrial rate is 70 or 80. So when that occurs, so there is no association between the two. So both are independent of each other, that is both have different rates, so that is AV dissociation. Okay, whereas in junctional rhythm, what is happening in the junctional rhythm? Both are derived from single focus, that is the junction, right? So this cannot be labeled as AV dissociation. This has to be labeled, the only difference is that both will have the same rate. Atrial rate also will be 70, ventricle rate will also be 70. If junctional rhythm rate is, let's suppose, 80, so both rates would be 80, atrial also, ventricle also. So you do not have AV dissociation in junctional tachycardia. Okay, so junctional tachycardia is another cause for Cannon wave. Okay, so that came as an MCQ. That is why I discussed with you. So now, what is regular and irregular Cannon wave? You can well imagine when AV dissociation is there, you will have irregular Cannon wave. Whenever you have junctional rhythm, you have a regular Cannon wave. Okay, so I end with this Cannon wave. The JVP is over. So let me go move on to the next topic. That is your. Okay, so the next topic is, when we discuss about the next topic, I'll continue with HOCM. Let's talk about HOCM. HOCM. Okay, and the last, when we discuss the pericardial diseases, we will talk about your chronic constrictive pericarditis, HOCM. Very important topic. This is the most important topic. So just pay attention. Once you understand it, you will be able to understand the whole of HOCM. Just understand, concentrate in the initial part. Okay. Uh, S3 is nothing much in S3. I'll talk about it later on. Okay. So HOCM, see, whenever there is an obstruction to the, for understanding the HOCM concept, you should understand the anatomy first. See, the whole during the uh, till since yesterday we have been talking about heart orientation. We discuss about RARV, how they are oriented. So now one diagram that I know is you are familiar with is this diagram, that this is the RA and this is the ventricle. Yes, you are familiar with this diagram. So since yesterday we have been drawing, so V1, V2, so they come like this. Yes, V4, V3 somewhere over here. So this is your heart diagram that you understand. Okay, so now from this diagram only I will tell you. See, what happens is, this is your AV valve. Yes or no? This is your AV valve, right? So this is your AV valve. So okay, so this is your AV valve present over here, right? And so what happens is, blood flow from atria to ventricle is happening in this direction, right? So this is your apex. Understood? And yesterday when I discussed about aortic dissection, I said aorta rises like this. While discussing the coronary artery also, I talked that aorta rises like this from above the ventricle. Okay, so you can understand, that means your mitral valve and your aorta, they are at the same end of the ventricle. Can you understand this? They both are at the same end of the ventricle. Okay, so now if I draw this diagram vertically, how will I draw the diagram? This diagram vertically, this diagram if I draw vertically, you will see that this is your mitral valve, this is your mitral valve, and this is your aortic valve. They both are at the same end of the ventricle. If you understand this much, I think the rest of things will become very, very easy. Okay, so the concept is, your AV valve in that diagram that you understand, since yesterday we have been drawing this diagram, so you know that diagram. So AV valve is over here. Okay, so that means mitral valve, tricuspid valve, whatever, whichever ventricle you will say, the same AV valve. So this is the AV valve, and this is the mitral valve, and aorta comes like this from here. Okay, so aorta originates from the ventricle like this. So see, I cannot show you, actually this anatomy becomes more clear if you see me directly. So that is why diagrammatically you have to understand that aorta originates from the same end of the ventricle. What I mean is the same end of ventricle. This is the apex of the ventricle. It's not that AV valve is like this, blood comes like this from the mitral valve and goes out into aorta from here. No, this is not happening. Blood goes out into aorta on the same end of the ventricle. You are understanding now? So aorta and mitral valve, they both are at the same end of the ventricle. This is the most important concept. If you understand that, you will understand the whole of cardiology. Okay. So now let's move on further. So this is the, if I draw it vertically, this is how I draw it vertically. And in the same diagram, above diagram, I want to show you that aorta is anterior. Yes or no? And mitral valve is posterior. Or if somebody want to say superior or inferior, that is also fine. Okay, you can say superior or anterior. Okay, and you can say mitral valve to be posterior or inferior. I'll use better term posterior. Okay, so use it posterior and anterior. Now, okay, now I have drawn it vertically. This is the anterior aorta and this is your posterior mitral valve. Okay, mitral valve has two cusps. One is the AML, anterior mitral leaflet. The other is your posterior mitral leaflet. Okay, so this is your anterior and posterior mitral leaflet. Now let's talk about it. Whenever there is any obstruction to LV contraction, what will happen? If it is a slowly developing obstruction, chronic process, 1 year, 2 year, 10 years, what will happen to the LV cavity? What will happen to the LV muscle if there is an obstruction? LV will undergo hypertrophy. Yes, absolutely right. So you will have LV hypertrophy present, and whenever there is an obstruction, so what is the type of hypertrophy that we generally see? It is this kind of hypertrophy. That means concentric hypertrophy. So this is what is obstruction. Whenever I say obstruction, obstruction can be at the valve level. When you say aortic stenosis. Okay, this is your aortic stenosis and this is causing the obstruction resulting in concentric hypertrophy. Okay, now in HOCM what happens? What happens in case of HOCM? In case of HOCM, see the hypertrophy is not concentric, but it is what kind of hypertrophy? It is asymmetrical septal hypertrophy. What is this asymmetrical septal hypertrophy? So this is your mitral valve and this is your aortic valve. So in case of HOCM, the obstruction is like the hypertrophy is like this. So obstruction is asymmetric septal hypertrophy. Okay, so now you will see the differences between the concentric hypertrophy and asymmetric septal hypertrophy. So what happens in case of asymmetrical septal hypertrophy? See, now at rest there is a large area for the flow to occur. Yes or no? In the beginning of the contraction. So what happens is when the systole occurs, this septum contracts, septum moves inside. Yes or no? This also moves inside. So when the LV contracts, what will happen? This septum will move inside. As it moves inside, what will happen to the area over here? This area, what will happen to this area? this area will decrease. The moment the area decreases, what happens to the blood that was going through this systolic? During systole it is happening, so blood is flowing from ventricle to aorta. So what will happen to the blood velocity when this area reduces? Velocity will increase. So velocity increases. Velocity increases. You have understood all this. So when the velocity increases, see, you always understand, whenever velocity increases, pressures decreases, pressures drop down. This is a Bernoulli's theorem. Okay, you can read your Bernoulli theorem in your books. Bernoulli theorem. So that means whenever velocity increases, pressure decreases. So what happens when the pressure decreases? Let's see. I again draw the diagram. So what will happen when the pressure decreases? See, this is your aortic wall, which is well open. There is no obstruction at this level. But obstruction occurs because of the asymmetrical septal hypertrophy over here. Okay. And now what happens? Because of the decrease in the pressure over here, decrease down. So what will happen? The mitral leaflet, which is very thin structure, it will move towards septum. It will move towards septum. You have understood? So the moment the mitral leaflet moves towards septum, how will it look like? It will look like, let me draw another diagram to show you how it will look like. It will be looking like this thing. Aortic valve is open, but what has happened? Because of the asymmetrical septal hypertrophy, the mitral valve moves like this, and this part of the leaflet is intact. Okay, so what has happened to the obstruction to the blood that is coming from ventricle to aorta? So what will happen to what has happened to the obstruction? Obstruction increases. So you again see the diagram, three diagrams that I have drawn. Again you see the diagram. See, to begin with, when we started the contraction, the septum was at this level. In this diagram you can see the septum. This was the septal position. Okay, but when it started contracting, this septum came very close to the mitral valve, resulting in increase in velocity and pressure drop down. The moment pressure dropped down at this area, so what happened to the mitral valve? Mitral valve, it moved towards the septum. It moved towards the septum. Okay, so that results in increase in obstruction. Okay, so this movement of the leaflet we call is at SAM. You must have read SAM in your books. It is SAM is systolic anterior motion. Systolic anterior motion of anterior mitral leaflet of mitral valve. So you have a systolic anterior motion of anterior mitral leaflet, and that is what is happening in case of your HOCM. Okay, so what is the result of systolic anterior motion? The systolic anterior motion, this what would be the result of systolic anterior motion? What is happening because of the systolic anterior motion? One thing is that the obstruction is increased in the later part of the systole. Second part is this part of their mitral valve is open now. So what will start? Yes, MR will start. So you will have MR also. So there are two things that SAM will cause. SAM will result in increase in obstruction and MR. Okay. So now you tell me what kind of obstruction is this? Is this a fixed obstruction or is it a dynamic obstruction? So you all say it is a dynamic obstruction. Why do you say it is a dynamic obstruction? See, why we say dynamic obstruction is because in the beginning of the systole, obstruction was very, very less, minimum obstruction. Whereas in the mid of the systole almost, when the septum came very close to mitral valve, what happened? There was increase in obstruction because of the SAM. So obstruction changes in the systole. As the systole progresses, obstruction increases. So this is what is known as dynamic obstruction. Okay. So if you have understood this thing, so that means the type of obstruction you have in concentric hypertrophy, it is a fixed obstruction, whereas in case of HOCM you have a dynamic obstruction. Okay, what are the other features? Let's talk about the other features of aortic stenosis and HOCM. What would be the pulse in case of aortic stenosis and HOCM? Okay, you write down pulse. These are the features. You divide your page. Okay, so you have aortic stenosis and you have HOCM. So, okay, let's see the aortic stenosis pulse. Aortic stenosis, it is a weak pulse. Why? Because obstruction is fixed. Right from the beginning of the systole, you have obstruction. So, blood is not able to reach aorta. It is going very slowly, slowly, slowly into the aorta. So, what will happen? The pulse that would be resulted in is a weak pulse, and we call it as pulsus parvus et tardus. Okay, whereas what is happening in HOCM? In the beginning, there was no obstruction. So immediately the pulse would be very rapid pulse in the beginning. But then suddenly obstruction occurs and the pulse volume decreases. Yes or no? And then there is just a little output that is there. So resulting in two peaks would be there. One is a spike like and the other is a dome pattern. So you have something known as spike and dome pulse, bifid pulse. This is a bifid pulse which is special type, which is spike and dome pattern. See, okay. So this is your pulse in your aortic stenosis and HOCM. I again tell you that during diastole there will be no obstruction. Why there will be obstruction in diastole? You will not say obstruction in diastole because blood is not going from ventricle to aorta during diastole. So you will not talk about obstruction in diastole. Mitral valve is normal, so there is no obstruction during diastole for mitral valve. In diastole only you talk about mitral valve. There is no obstruction in mitral valve. Okay. So only in systole you will talk about obstruction. And what is the type of obstruction in HOCM? It is a dynamic obstruction. In the beginning there is no obstruction, but in the systole later on it will become more severe. Okay, so let's move on further. So the other features. What are the other features of HOCM and aortic stenosis? Murmur. Let me talk about murmur. What would be the murmur in aortic stenosis? Which is the murmur? Ejection systolic murmur is there in case of aortic stenosis. Same ejection systolic murmur would be there in case of HOCM. But what is the difference? In aortic stenosis, it radiates to carotid. Whereas in HOCM, it is a localized murmur. Okay, it is a localized murmur. Localized, not loud, localized. So next is your carotid impulse. This came as an MCQ, carotid impulse. See, you tell me what would be the carotid impulse in case of your aortic stenosis. You know it would be weak, but what would happen to your HOCM? Initially, when the blood goes rapidly into your carotids, what would be the carotid upstroke? No, I am talking about not carotid impulse, upstroke. That is, the moment systole starts, blood goes into carotid and carotid dilates. So that dilatation is known as upstroke. So what do you think would be the upstroke in HOCM? Will it be weak or it will be very rapid upstroke? Yes, why it would be rapid? Because initial part of your systole there is no obstruction. So initially it would be very rapid. But then what will happen? Because obstruction will come in the mid of the systole, so the output will reduce, and then you will have your this thing happening. The out pulse will reduce. Okay, so output will reduce. So this is what are the features of your impulse and the murmur. And another important finding is your maneuvers. What happens to the murmur with preload in case of aortic stenosis? If you increase the preload, murmur will increase. If you decrease the preload, murmur will decrease. That is true for all the sounds. But what happens in HOCM? You yourself see. If your heart is like this, let me see, draw the heart. This is your HOCM. Okay. And now, this is your HOCM. Okay. This is a normal heart with normal size of the LV. If I increase the preload, what will happen? Your LV cavity will dilate. So now LV size is like this. So now you tell me, in which case you will have more obstruction, with increased preload, this condition, or in a normal LV? In a normal LV. So that means increasing the preload results in what? Decrease in obstruction. So increasing the preload means decrease in obstruction, means decrease in murmur. Decrease in murmur. So HOCM is the only condition, along with MVP plus MVP, HOCM plus MVP, these are the only two conditions where murmur decreases on increased preload. Where murmur decreases with increased preload. Okay, so this is very easy. Next is your, again, what will happen with the contractility? You tell me. If the heart contracts, let's suppose this is your normal heart. I am drawing the normal heart. Okay. Now when it contracts to this much, it will cause more obstruction, or when it contracts less, this much, it will cause more obstruction. So obstruction will be more if your contracts more, and if your contractility is less, obstruction would be less. Yes or no? You have understood? If your LV contractility is less, your LV obstruction would be less. So less contraction, less obstruction. Whereas more contractility means more obstruction. You have understood this concept also. So that will result in what is happening? Okay, so this thing you have understood. Now let's move on to the symptoms of HOCM. Now you will understand further symptoms of HOCM. What are the symptoms of HOCM? Symptoms, what do you think? They will be present at rest or on exertion? Rest or exertion? When the patient runs, his LV starts to contract more vigorously. So what will happen to the obstruction? During exertion, the obstruction will be more because contractility is more. Whereas during rest, LV is not contracting that much. so that will result in less obstruction. Okay, so most of the symptoms the patient will have during exertion, not at rest, not at rest. So what happens on exertion? He will have dyspnea. Why dyspnea is present in HOCM? Dyspnea means pulmonary edema. So what is the cause of pulmonary edema in this? That means pulmonary edema, PCWP. What is PCWP in HOCM? PCWP is increase. So you have understood the concept. Okay. So left sided any obstruction you will result in increased PCWP. If your PCWP is high, what will happen to pulmonary lungs? Pulmonary edema will occur. So that will result in your dyspnea. So you have a post capillary dyspnea. Okay. Now this patient will also have angina. Okay, so now what is happening is angina. So any patient of angina comes to you, the first drug that you give to relieve the angina is sorbitrate. Now when you give sorbitrate to this patient, what will happen when you give sorbitrate to this patient? HOCM patient comes with angina and you give sorbitrate. What will happen to the angina? What will happen to the angina? Increase, decrease, no effect. See what sorbitrate does. Sorbitrate results in decrease preload. Very good. So if the preload is reduced, so what will happen to the LV cavity? LV cavity will be reduced. So if LV cavity is decreased in size, so your obstruction will increase. If your obstruction is increased, so your oxygen demand is increased, that results in your angina, more angina. Okay, so your angina will increase with sorbitrate. This is the classical sign of HOCM. Third is your syncope, exertional syncope. Okay, so these are the three symptoms. Now, how can you remove the symptoms? By reducing the obstruction. How can you reduce the obstruction? The one way of reducing the obstruction is, yes, any drug that will reduce the obstruction. Yes, nitrates will be contraindicated in HOCM. You are right. So drugs that reduces the contractility should reduce the obstruction. What are the drugs that reduces contractility? Yes, what are the drugs that reduces contractility? So reducing the contractility will reduce the obstruction. So they are the drug of choice. Beta blockers are the drug of choice. Okay, and CCBs, out of CCBs we give verapamil, that can be given as a drug of choice. Okay, so but if single answer, drug of choice is beta blocker. First is beta blocker, then verapamil. Okay, next, how can you again reduce the obstruction? By increasing the preload also. Increasing the preload, that means you ask the patient to stay hydrated. So what are the drugs that you will not give to increase the, that will increase the symptoms? Drugs that increase the symptom. What are the drugs? Diuretic, yes, reducing the preload. Nitrates, we have already reducing the preload. And any drug, yes, that increases the contractility. What are those drugs? Beta agonist. Beta agonist, they will cause the contractility to increase and will result in more obstruction. So more symptoms. Okay, so inotropes. So now you have understood the concept of HOCM. Okay, let's move on further. So you have all understood the HOCM. Okay, so I move on to the next important topic, pericardial diseases. Okay, pericardial diseases. In the pericardial diseases, we will be talking about four diseases. What are these diseases? chronic constrictive pericarditis. Okay, RCMP, that is restrictive cardiomyopathy. Restrictive cardiomyopathy. Third is your RVMI, and fourth is your cardiac tamponade. Cardiac tamponade. Okay, so let's talk about all these four diseases independently. See, you have to just pay attention for some time, and once you understand it, it's very very easy. Okay, just like HOCM, you have to understand the basic concept. Once you understand it, then the things will become very very easy and very fast. Okay, so let me tell you about pericardial diseases. See, first let us talk about normal thing. Normal thing is, what happens normally? Your LV or RV, it contracts. Okay, so it contracts, resulting into systole. Okay, after systole, during systole, that means RV and LV, how they look like during systole? They have contracted. Yes, so they have contracted, resulting in your LV systole. Now, when they relax, what happens during relaxation? Relaxation, their cavity size increases. Cavity size increases. Okay. During isovolumic relaxation, what will happen to the cavity size? It will increase the cavity size. But what happens to the pressure inside? What happens to the pressure inside? See, any cavity that expands in size without filling, what will generate? It will generate something known as suction pressure. Yes, today only we did in the re-expansion pulmonary edema. What happens to the lungs when lungs expand without air? Lungs expand without air, it creates a suction pressure. Similarly, when the heart chambers they dilate without filling, without blood, they will result in what is known as suction pressure. Because of this suction pressure, what happens to the AV wall? This opens the AV wall. Okay, so first thing important is your suction pressure that opens the AV wall. The moment AV valve opens, the blood starts to flow. Okay, this much we all know. So now what happens to the blood? When this blood reaches and touches the ventricle wall, what will happen to the ventricle wall? Now, see, if you see, if I am filling a balloon, what happens? Balloon starts stretching. The more I fill it, it stretches more. So what will happen to the pressure inside the balloon? Will it increase if its volume also increases with the filling? What will happen to the pressure? Will it increase significantly or it will increase slowly? The pressure, see what happens is, it will increase slowly because balloon also expands. Balloon is expanding as it is filling. So what will happen to the pressure inside the balloon? It will be less increase, slowly increase. Yes. So similarly in the ventricles, what happens is, when the ventricle is filling, the ventricles are elastic structures, so they expand themselves. When they expand themselves, what happens is that the pressure in the ventricle, it increases, but very very slowly it increases. Okay, so this results in what? This results in continuous passive filling to happen. Okay, so blood will continue to come from atria to ventricle. Why? Because ventricles are also expanding and the pressure is not increasing significantly in the ventricles. Okay, if ventricle is a stiff structure, let's suppose ventricle is not able to expand, then what will happen? Ventricle is not expanding, ventricle is fixed structure. So what will happen? The moment blood goes into the ventricle, the blood will go into the ventricle, but ventricle will not expand. So what happens to the pressure in the ventricle? Pressure in the ventricle will rise suddenly, fast increase in pressure, and that will decrease your passive filling. Yes or no? So suddenly your pressures will begin to rise, and your passive filling will decrease. Okay, so if you have understood this thing, so normally during diastole, so two things are important. One is your suction pressure to open the AV valve and start the filling process. But for maintenance of filling, what is required is the elastic property of the ventricle. Okay, so now you have understood these two things. Let's move on to the different kind of diseases. What are the different diseases that we will what happens in different diseases? Let's see. See, in the CCP, how it is in the CCP, what is the pathology in CCP? This is your ventricle. The whole of the heart is covered by a calcified pericardium. The whole of the heart is covered by calcified pericardium. Now, systolic function is normal. Systolic function is normal. Okay. So your systolic function is normal. Again, ventricle contracts. So in JVP also I will draw the again the JVP. Systolic function is normal. So systolic part of the JVP, that is the X descent. You have a C wave, X descent, and a V wave. So all these would be normal. X and V wave would be normal. CXV, they all are the systolic waves, so they all will be normal. Okay, now what happens is, again, when the ventricle expands during relaxation, what will happen? AV valve will open. As the ventricle, after the contraction, it expands, the AV valve will open and the blood will start flowing into the ventricle. So the moment blood enters into the AV valve opens, blood starts to flow into ventricle. What happens to the atrial pressure? Atrial pressure will suddenly drop down because of the movement of the blood. Okay, so now, but when the blood reaches the ventricle wall, what happens to the wall? Wall is stiff. It is not moving beyond a particular point. It is fixed. It cannot go beyond this point. So what will happen? The pressures in the ventricle will suddenly increase, and your pressures in the ventricle suddenly increases and a plateau is reached. And a plateau is reached. You are understanding this concept? See, what is happening is, I again repeat, because this is slightly tougher thing. See, when I told you in a normal heart, what happens is, the uh, after the AV valve opens, because negative pressure is there in the ventricle, that is results in the opening of the AV valve. Once the AV valve opens, blood starts to flow from atria to ventricle, right? So that movement of the blood from atria to ventricle, that movement results in your Y descent. Okay, so that movement is sufficient to cause Y descent. Why? Because blood has come from atria to ventricle, so that will result in decrease in atrial pressure, and that is a Y descent. Okay, now, so now what happens is, when the blood reaches the ventricle, now if ventricle normally is an elastic tissue, so what happens is, ventricle starts to expand along with the filling. So what happens is, ventricle pressure does not rise much. So if ventricle pressure does not rise, so what happens is filling continues. So the ventricle pressure does not rise and filling continues into the ventricle. Understood? So that results in what is known as, there is no rapid rise in the pressures of the ventricles. Okay, that is a normal phenomena. Okay, now whereas in case of your CCP, chronic constrictive pericarditis, what is happening? Again, after the systole, when ventricle starts to dilate, ventricle pressure is decreased, so AV valve will open normally, and the moment AV valve opens, blood will start to flow into the ventricle. Blood move from atria to ventricle, so you have a rapid wide descent present. But when the blood reaches the ventricle, it will find that ventricle is very stiff, it cannot expand. The moment ventricle does not expand, what will happen to the ventricular pressure? Ventricle pressure rises. So the moment ventricle pressure rises and it becomes equal to the atrial pressure, yes or no, it will increase and it will become equal to the atrial pressure. So what, after a particular moment, what will happen? Both the pressures are equal. Which stage is now this stage is reached is diastasis. So diastasis, and this is what is plateau. Plateau is nothing but diastasis. So that means there will be no more flow of blood from atria to ventricle, and there will be no more increase in the atrial or ventricle pressure. Okay, so again, this is an important concept. So just write it down. We'll repeat it again in RCMP because this is the basic thing that is happening in all these conditions. So what is happening? You have a normal X descent, you have a Y descent, you have a square root sign. What does it look like? Square root sign. This is a square root sign. Okay. So you have a square root sign in case of pericardial chronic constrictive pericarditis. Okay, next. Let's move on further. What about the when the atria contracts, what will happen to the A wave? Because see, passive filling is reduced, so what will happen to the active filling? Active filling has to increase, so atria has to generate more pressure, so A wave will be increased. So you have an increased A wave, you have a square root sign, you have an X, normal X descent and increased Y descent, almost rapid Y descent, normal to increased Y descent. Okay, so these are the features of chronic constrictive pericarditis. Now let's move on further. I'll explain you again. This is the same thing that I will explain you again. Now in case of RCMP, what is happening in RCMP? In RCMP again, see your myocardium, this is your normal heart, this is your normal myocardium. What happens in RCMP? The most common cause of RCMP, MCQ, most common cause of RCMP. This is an MCQ. This is amyloidosis. Most common cause of RCMP is amyloidosis. So what happens in case of amyloidosis? Again, there is a deposition of amyloid within the myocardium. So this will make the myocardium what? Stiff. So again, what is happening? Systolic function is normal. The same thing is happening. Systolic function is normal. So when the LV contracts or RV contracts, it pushes the blood out. So systolic function is normal. Now when it starts to dilate, again ventricle pressure drops down. As the pressure drops down, AV valve opens and the passive filling starts. Passive filling starts. Right? So what happens to the X and Y descent? Normal X and Y descent, normal X, V and normal Y descent. Okay, so now, but when the blood reaches the ventricle, how is the ventricle? Ventricle is again stiff. Yes or no? So because ventricle is stiff, so what will happen is the ventricle pressure rises suddenly and the two pressures, atrial and ventricle pressures, they rise, and that results into your plateau formation. Both become equal and that is the plateau formation. And after this plateau, again atria will contract, resulting into large A wave, increased A wave. Okay, so it's almost the same as chronic constrictive pericarditis. You will have all the same things: increased A wave, square root sign, normal X descent, Y descent would be increased. Okay, you have understood now. So same thing is happening even in the RCMP. So what is the difference between the two? The difference between the two is there is something known as, see, Y is almost normal to increase. So you can take it to be normal to increase. So you will not understand, that is not required. Okay, so normal to increase. Okay, next point is, what is the difference between the two? The difference between the two is something known as ventricular interdependence. Just write it down, I won't explain you. Okay, ventricular interdependence. So this ventricular interdependence is seen in chronic constrictive pericarditis, not in RCMP. Not in RCMP. Okay, what is ventricular interdependence? I'll just explain you very briefly. See, you have an RV and LV. This is your atria. So what happens is, whenever your RV blood increases, RV dilates. Where it dilates? It dilates in this direction. So it will accommodate blood by dilating in this direction. Whenever LV blood increases, LV dilates in this direction. Yes or no? Okay. Whereas in chronic constrictive pericarditis, what is happening? In chronic constrictive pericarditis, the ventricles, they cannot dilate this direction. They cannot dilate. Why they cannot dilate? Because there is a fixed calcified wall present. So they cannot dilate in that direction. So where will they dilate? If the RV gets the blood, where will it dilate? Septum will be pushed towards the LV. So what will happen to the LV blood volume? It will decrease. Okay. So when the LV receives the blood, when the LV volume increases, what happens to the septum? Septum is pushed towards the RV. So RV volume decreases. So for example, if the total blood volume is 100 ml, RV normally is 50 plus LV is 50. If I make RV as 70 ml, so LV will reduce to 30 ml. Why? Because the total volume is fixed. Total volume of the heart is fixed, that is 100 ml. This is what is happening in chronic constrictive pericarditis. Okay. So you are right, sudden blood flow will cause this thing, that is the steep Y descent that we have. Okay. So that is what is happening in case of your ventricular interdependence you see in CCEP, not in RCMP. Okay. Now comes the third thing. Third disease. What is the third disease? RVMI. Let me discuss RVMI. So till now everything is same except for ventricular interdependence. So what happens in case of RVMI? See, in RVMI your RV dysfunction is there. So that means RV dysfunction means RV dilatation. So let me draw the diagram for RVMI. So this is your RV, it's dilated and you have like this. Okay, RV is dilated, RV dysfunction is there. Now again what will happen? During diastole, there will be a negative pressure in the ventricles resulting into your opening of the AV valve and the movement of blood goes into your ventricles. Okay, so this results into your movement of blood from atria to ventricle, right? So again what will happen? RV is already dilated. See, if you have already a stretched balloon, will it increase further? What will happen? Will it increase further? It will not increase, dilate further. So what will happen to again the pressure over here? The moment blood goes into the ventricle, into the right ventricle, what will happen to the pressure inside the right ventricle? Again it will increase. Why? Because RV is already dilated, it cannot dilate further. So what will happen is, you will have a Y descent, V and Y descent, rapid Y descent, and rapid increase in the ventricle pressure and the atrial pressure, and then you have a plateau, and now you will have an increased A wave. Okay, so this is what is your happening in case of RVMI also. So in RVMI also you have a Y descent, you have a V wave, you have a square root sign, all are same, all are same. A wave, increased A wave. Now what is the difference? Difference is in whenever you have an RV dysfunction, what will happen? RV dilates. Whenever RV dilates, your AV valve also dilates. So whenever AV valve dilates, what will happen? Which regurgitant murmur will start? Tricuspid regurgitation will start. Whenever any chamber dilates, you have a regurgitation. When RV dilates, it causes TR. When LV dilates, it causes MR. When aorta dilates, it causes AR. Okay, this you should always remember. So you will have TR also in case of RVMI. When there is a TR, what happens to the X descent? Yes, what will happen to the X descent if you have a TR? What will happen to the X descent if you have a TR? X descent would be decrease or absent X descent. Yes or no? So in case of TR, you will have there will be a C wave, but there will be increase in the C wave, and there will be very small X descent, and then again there is a V wave, and then there is a Y descent. So you have a V, Y square root sign, then you have an A wave, and then you have a decreased X descent, again you have a V and Y descent. Okay, so what is the difference between RVMI from rest of the two conditions, CCP and RCMP? The only difference is RVMI has decreased X descent. That is because of the TR, whereas the rest two conditions, their X descent is normal. Their X descent is normal. Okay, rest all the findings, Y descent would be normal or slightly increased, square root sign would be same, A wave would be prominent. So these all three things will be there. Okay, see the concept. I'll just overview. I'll give you very easily. Ultimately, you have to remember that X descent is less. What happens to Y descent? That is comes as an MCQ. So just I try to explain you so that you can remember the things. So let me again explain you. See, whenever LV relaxes, isovolmic relaxation occurs, the ventricle pressure decreases. Okay, we are talking about RV, so RV pressure decreases. So the moment pressure decreases, AV valve opens and the blood starts to flow into the ventricle. This much you all know. Okay, so that results in Y descent. Okay, so now normally when the blood goes into the ventricle expands. Why? Because it is an elastic structure. So the increase in ventricle pressure does not happen very rapidly. That is why you have a passive filling that is around 70%. So 70% of the ventricle it fills before its pressure rises slightly. Okay, that means it's a very slow increase in the pressure. That primarily is because the RV it expands. Okay, now when there is an inelastic RV, decreased elasticity of RV, conditions are like CCP. What is happening in CCP? You have a calcified shell. In RCMP, myocardium has amyloid deposited, so elasticity is less. Third condition, RVMI, already it is a dilated cavity, it cannot dilate further. So in all these three conditions, RV size does not increase on filling. So what will happen if size does not increase? So what will increase? Pressure will increase. So pressure increases rapidly, and that is the pressure that you see as increase in pressure and square root sign. Okay, so all these three conditions, they have a normal Y descent, they have a square root sign, they have a prominent A wave. Okay, but out of these three, only RVMI has decreased X descent. Why? Because of the presence of TR. Okay, rest don't have TR, so you will not have a decreased X descent in CCP as well as in case of RCMP. This much you have understood or not? I'll move further. Okay. Now let's move on further. After this topic, we'll take a tea break and then we'll continue for the till 6 o'clock and then we'll finish. Okay. Now see what is happening. This is your just let's finish off this topic. Okay. And this is your decreased X descent only seen in case of RVMI. That is the only exception. Okay. Now let's talk about cardiac tamponade. Cardiac tamponade, you just remember one thing. Cardiac tamponade, it is an exception. I won't explain you the method. But only thing that you will try to understand is that cardiac tamponade result, it is an exception to all these three conditions. What is an exception? Number one exception is there is a decreased Y descent in cardiac tamponade. Decreased Y descent in cardiac tamponade. Okay, so that means what? Y descent was normal or increased in rest all the three conditions, RVMI, CCP, RCMP, but it is decreased in cardiac tamponade. Okay, so this is one exception in cardiac tamponade. The another exception is the Kussmaul sign. What is Kussmaul sign? Yes, passive filling is greatly reduced. Okay, what is the Kussmaul sign? See, Kussmaul sign means when you inspire, your JVP increases. That is a Kussmaul sign, because normally what happens? Yes, paradoxical increase in JVP on inspiration. So what happens normally? Normally what happens? When you inspire, what happens to the JVP? JVP decreases. Why it decreases? Because the blood from the veins, they go into the RV. Yes or no? So whatever the blood is there in the veins, they drain into the RV. And what happens to RV? RV dilates. RV is a elastic tissue, it dilates. So it takes up all the blood with itself and does not increase the pressure. Therefore, when you inspire, the entire blood from the veins goes into RV and RV does not increase its pressure. So your JVP does not increase but it decreases. This is a normal condition. But if let's suppose RV is non-elastic, RV is hard, RV is not expanding. So what will happen? When you inspire, blood flows into the RV but RV is not taking the blood. So what will happen to the RV pressure? RV pressure will rise. If RV pressure rise, what will happen to the JVP pressure? RA pressure will rise and JVP will rise. So that is what is known as Kussmaul sign. Okay, so you can tell me Kussmaul sign, what will happen to the Kussmaul sign? Will it be present or absent in case of CCP, RCMP and RVMI, where RV elasticity is reduced, where RV is not expanding? What will happen to the pressure, JVP pressure on inspiration in all these three conditions? JVP pressure will increase in all these conditions during inspiration. And what will happen to Kussmaul sign? Kussmaul sign would be present. Kussmaul sign is increase in JVP on inspiration. So it will not be absent, it will be present in all these three conditions. You are getting the point? Yes or no? Okay, so it's a simple thing. See, we are using the same concept again and again and again. So now you must have understood it. We use the same concept for CCP, RCMP. We are using the same concept for RVMI. In all three conditions, what is happening is RV is not expanding. So RV is not expanding, one because in CCP because of the calcified shell, RCMP because myocardial elasticity is reduced, in RVMI it's already dilated, so that results into this thing. Okay, so reasons are different but all three results in Kussmaul sign positive. So what is the exception in cardiac tamponade? Kussmaul sign is absent. This is an exception. Cardiac tamponade is an exception. Cardiac tamponade is an exception. Kussmaul sign is absent in this. Okay, so now let's move on further. Pulsus paradoxus. Pulsus paradoxus, we see the pulsus paradoxus. The most common cause of pulsus paradoxus is cardiac tamponade. Most common cause, pulsus paradoxus, cardiac tamponade. Okay, then comes the CCP. CCP also causes pulsus paradoxus. And least is uncommon causes are uncommon. RVMI and your RCMP. They are uncommon causes. They are also causes, but they are uncommon. Okay. So I think I have made the things very clear. See, don't get confused. The only thing is you have normal x descent, you have prominent y descent, you have a square root sign, you have a prominent A wave in CCP and in RCMP. In CCP, extra thing you have is ventricular interdependence. Okay, that you just remember because that is the ultimate you have to remember. And the RVMI addition to all these findings, it also has decreased X descent. Decreased X descent. Okay, next is your cardiac tamponade. You have an exception there, two exceptions, that there is a decreased Y descent in cardiac tamponade, whereas in all the other three conditions you have normal Y descent or increased Y descent. Okay, whereas in case of Kussmaul sign, in all the rest three conditions you have Kussmaul sign present, whereas in case of cardiac tamponade Kussmaul sign is absent. Okay, we won't discuss about why, you will not understand. Okay, so let us finish this topic of CCP. What is the most common cause of CCP? Tuberculosis is the most common cause of CCP. Just finish this topic. CCP, the most common cause of CCP is tuberculosis. Second thing is your in chronic constrictive pericarditis. See, ST elevation. Yesterday when I was telling you, I again told you that it is seen in only in acute pericarditis, not in chronic pericarditis. So don't typically write it down in CCP that ST elevation is not present. Okay, and the management, what are the other signs in chronic constrictive pericarditis? There is something known as broad bend sign. Broad bend sign. Okay, and there is something known as Frederick sign. So what is broad bend sign? Just remember it is seen in CCP. You need not know what it is. Broad bend sign is seen in CCP. And Frederick sign. Frederick sign is nothing but what happens in the JVP. You have a prominent X, prominent Y. So this W pattern in JVP is what is known as Frederick sign. Okay, so Frederick sign you will see in both CCP and RCMP because you have both X and Y prominent in case of CCP and RCMP, whereas in case of RVMI you do not have X descent. In case of cardiac tamponade you do not have Y descent, so you do not have Frederick sign in those two conditions. Okay, now that finishes the CCP. Next is your let's discuss about RCMP. I have already told you the most common cause of RCMP is your amyloidosis. So no need to go further. That finishes the RCMP. Last condition that I want to discuss, RVMI, we have already discussed. So the last condition left is your cardiac tamponade. So what is the cardiac tamponade that we are going to discuss? Okay, so the only last condition is cardiac tamponade. This is the last thing that I am telling you, just the points. You just have to write the theory. Don't apply your brain. Okay, just the theory we have to discuss. Cardiac tamponade. See, what are the causes of cardiac tamponade? Number one cause. Anybody? Yes, we have already discussed cardiac tamponade causes. Two causes we have already discussed till now in the last one day. Yes, what are the cardiac tamponade that we have discussed? Yes, Mysore is right. What type of MI? Complication of anterior wall MI. What type of MI? It would be transmural MI. Okay, so that is anterior MI, transmural MI. You will have a complication of cardiac tamponade. Yes, yesterday we did one more cause, aortic dissection. Aligarh is right. Aortic dissection is the another cause that can result in cardiac tamponade. So these are the clinical settings they will ask you. Okay, third is right, trauma. Some of you said trauma can also cause cardiac tamponade. That is a commonly asked question. And fourth point that you see cardiac tamponade is after cardiac procedures. Cardiac procedures. After cardiac procedures. After cardiac procedures, you can develop cardiac tamponade. Okay, so cardiac surgery, cardiac intervention, whether it is stenting or whatever, so you can develop this thing, pericardial tamponade. Okay, so these are the common clinical situations. See, I am telling you the common clinical situations that come in the exam, in the MCQ. Okay, now let's talk about further. What would be the clinical signs? Clinical signs in cardiac tamponade. What are the clinical signs? Yes, what is happening in cardiac tamponade? Your cardiac tamponade, your heart is all surrounded by fluid. Yes or no? And that too at high tension. Fluid pressure is very high. So what happens is your fluid pressure is high. So resulting into what? It will result in increase in JVP. One thing. Number two, it will muffle the heart sounds. Muffle the heart sounds. Muffle the heart sounds. And the third point is because venous return is reduced, so cardiac output is reduced, resulting in hypotension. So three things, this together we call it as backstride. No, not increase BP, decrease in BP. Increase in JVP, decrease in BP, and your muffled heart sounds. That is what is you have this thing. No, Kussmaul sign is not increase JVP. Increase JVP does not mean Kussmaul sign. Kussmaul sign means increase in JVP during inspiration. That is important point to understand. Okay, okay. Now let's move on further. If there is something known as Ewart sign, you write down Ewart sign. What happens in Ewart sign? See, this is given in your Harrison, so it becomes important. Ewart sign means whenever, just try to understand, this is your thoracic cavity. This is your thoracic cavity. So what happens is you have a lung in this. Yes, you have the lung in this. You have a heart in this. Okay. Now, when the tamponade occurs, this will occupy more area. Yes or no? The more it occupies the area, what will happen to the lung over here? What will happen to the lung? Yes, what will happen to the lung? Lung will undergo collapse. So compression or collapse, if your lung undergoes collapse, so what would be the signs when you auscultate lung at this point? What is this point? That is below left scapula. If you auscultate the lung, you will find the signs of collapse. Okay, so that is what is known as Ewart sign. Okay, now let's move on further. What happens to the ECG? ECG in case of cardiac tamponade. What is the ECG in cardiac tamponade? Yes, you are right. Electrical alternance on ECG. See, what is happening in electrical alternance? Your ECG, because your heart, it is free to move within the pericardial cavity. Okay, leave it. That results in electrical alternance. This is electrical alternance. Okay, what is the management? Management is pericardiocentesis. Pericardial centesis. So that is the management of cardiac tamponade. Okay, so that finishes the topic of pericardial diseases. See, the will do the MCQs, you will automatically get all the things right. You will understand everything. Okay, so you want to do the MCQs now, or you want to do the MCQs after the break? Okay, so let's take the break. This will be the last break. We are already running short of time, so we'll take 10 minutes break, and we'll reassemble at around 4:30, 35. 35 will reassemble. Okay, and many people they want break, so we'll reassemble at 4:35. Just 12 minutes break, and sharply at 4:35 I'll start. Okay, and I'll take up the questions whatever few are asking meanwhile. Okay, so we'll reassemble at 4:35. Okay, tell me, this is Miraj, which they are telling me is your reversible cardiomyopathy cause. Reversible cardiomyopathy, there are so many causes of reversible cardiomyopathy, but what is important for you is alcohol cardiomyopathy, selenium deficiency. Selenium deficiency is one another that can cause reversible cardiomyopathy, and the third, very commonly asked, is your beriberi disease. Okay, so uh, that finishes your Takotsubo is another cause for your reversible cardiomyopathy. It presents just like an MI. Its total presentation is like an MI, but it is totally reversible. Coronaries are normal. Okay, so that is true. That is another cause of the reversible cardiomyopathy. Okay, so let's take a break. After 10-12 minutes, important topics left are, see, we have to discuss VT versus SVT. Last topic that would be some of the valvular heart diseases I have to discuss, and the another important topic that is left for me to discuss is the electrical and mechanical association. That is important, electromechanical association. So few things are left, and we'll do the MCQs. That's it. That's it for today, and I think that is enough for cardiology. Okay, let's meet after 10 minutes. Okay, let's start the class. The last section of the class this will be, and many people have asked me many questions. See, don't ask me your personal problems. If you have any problem in any particular thing, in any cardiology, anywhere, you can ask me directly on my mail. Okay, over here it is difficult to cover a new topic at all. I won't cover new topics. I'll just stick to my topics. In those topics, if you have problem, then we will discuss. Okay. So let's move on further. You are ready? Everybody is ready there? So everybody is ready. Yes. Shall we start? Okay. We'll do some of the MCQs, and yes, everybody is ready. Yes, shall we start? आई थिंक मुझे लग नहीं रहा वहाँ आवाज़ जा रही है।
अच्छा, ऑडियो का इशू है।
क्योंकि कोई रिस्पांस नहीं आ
नहीं
रहा।
सर, वो चैट डिसेबल है ना,
ओके
तो
ओके,
वो मैं कर देता हूँ।
चल मैंने कर दिया। ओके okay, let's start and do the some of the MCQs, and then we'll see. See, doing the MCQs help us knowing what we know about the subject. Okay, so let's do it. Okay. See, a 30-year-old male presents to the emergency department with history of sudden onset breathlessness. On examination, JVP is raised and an inspiratory decline in systolic blood pressure of 14 millimeter mercury is observed. So what is there? A 30-year-old male with acute onset breathlessness, JVP is raised, and what is this sign? Inspiratory decline in systolic blood pressure of 14 millimeter mercury. What is this? This is pulsus paradoxus. Okay, so no, not small sign, it is pulsus paradoxus. What is pulsus paradoxus? Pulsus paradoxus means a fall in systolic blood pressure of more than 10 millimeter mercury on inspiration. Fall in blood pressure, systolic blood pressure by more than 10 millimeter mercury on inspiration is your pulsus paradoxus. Okay, or exaggerated fall, that is the same thing. Okay, so this is JVP, raised JVP, and pulsus paradoxus, all are true about the condition. So what is the diagnosis of this condition? Just tell me first the diagnosis of this condition. A 30-year-old male with raised JVP and inspiratory and pulsus paradoxus. What is the diagnosis? See, if you read the question, you are saying cardiac tamponade because on the basis of your choices, right? But as per question is concerned, if you see the question, there is no direct evidence of cardiac tamponade. You have only raised JVP and pulsus paradoxus. This you can see in so many conditions. You can have raised JVP and pulsus paradoxus in your lung causes with cor pulmonale. Yes or no? You will have raised JVP because of RV dysfunction. You can have pulmonary embolism also. Yes, you can have CCP. You can have so many causes, right? So you can have so many causes of this of this question. So but examiner has not given you the direct evidence it is cardiac tamponade. So sometimes these kind of question comes. So how to answer them is that you should try to see the question, the choices that he has asked. Choices like electrical alternance, Y descent, small sign, that means he is talking about some of the pericardial diseases. And what is the pericardial disease that is acute in onset? Pericardial disease that is acute in onset is your cardiac tamponade. You cannot have a pericardial disease CCP acute onset. You cannot have RCMP with acute onset. So these all are chronic diseases. Okay, so see these things you cannot do anything about it. If the examiner does not give you directly what it is in the question, you have to somehow find out what is he is trying to ask. Okay, let's see. It is a cardiac tamponade. Then in cardiac tamponade, what is the answer I told you? Small sign and rapid Y descent, these are the two things exceptional which are not present in cardiac tamponade. Okay, so these are the two things which are not present in cardiac tamponade. Rest, these are different things from your other pericardial diseases. Okay, post-operative surgical patient develops sudden hypotension, raise central venous pressure, pulses paradoxus at the fourth post-operative hour. The most probable diagnosis is, what is the most probable diagnosis? Cardiac tamponade. Okay, can you tell me why it is not mediastinal bleeding? Why it is not mediastinal bleeding? After surgery, after 4 hours, you can have even excessive mediastinal bleeding. That can also result in hypotension. Then what is there in the question that it is a cardiac tamponade? Absolutely right. Aligarh is absolutely right. See, raised JVP you will never have in case of excessive bleeding. And to tell you for Mysore, which is saying pulsus paradoxus can be sometimes seen in hemorrhagic shock. Hemorrhagic shock means excessive bleeding shock. Okay, so time and again I tell you these are sometimes exceptions that are there, but central venous pressure raised CVP you will never see in a patient of hemorrhagic shock. Okay, a 40-year-old female intolerant to cold, constipation and hoarseness of voice was found to have cardiomegaly on chest X-ray. What is the diagnosis? First, what is the clinical problem? Cold, constipation and hoarseness. Female. What is the condition? Cold, constipation and hoarseness. Hypothyroidism. Absolutely right. Hypothyroidism, even if you don't make the diagnosis of hypothyroidism, whenever you have to see any cardiac structure, what is the investigation of choice? Echocardiography. Whenever any cardiac structure, echocardiography, until and unless specified specifically. Okay. A patient presents with engorged neck vein, BP of 80, pulse rate of 120 following a chest trauma. What is the diagnosis? See, these kind of questions keep coming again and again. So a patient presents with no, why you are saying backstride? Did they tell you that there is a muffled heart sound? You do not have a muffled heart sound, so it's not a backstride. Okay, so the point is you have hypotension and you have raised JVP. These are the only two features that are present. Okay, so after chest trauma, if you have tension pneumothorax, that can also result in raised JVP and hypotension. Yes, so but in the question they will give you something about mediastinal shift, that there is a mediastinal shift, then only it will be a tension pneumothorax. You cannot assume for yourself that there is a mediastinal shift. So whenever you try to attempt these questions, clinical problems, just stick to the information that they have given. Don't assume yourself that, oh, this can be there, this can be there. No, whatever is there, it is there, and if not mentioned, it is not there. Okay, so that means mediastinal shift is not there in this patient. You do not have decreased breath sounds. Okay, so it is not there. Okay, so these two things are not there, so the diagnosis is what? Cardiac tamponade. Rapid X descent is unlikely in. The only condition out of these four conditions that have a decreased X descent, that is your RVMI. Understood? So RVMI is the only condition where you have decreased X descent. Cardiac tamponade is the only condition where you have decreased Y descent. And chronic constrictive pericarditis and RCMP, they have both X and Y descent. Okay, so I think now you have understood the questions and you have understood the concept also. Again, see, cardiac tamponade, they keep on asking this question. This is very important question. Cardiac tamponade, enlargement of the cardiac slit, yes. Electrical alternance, muffled heart sounds, all are present. Electrical alternance. Okay, so these three things would be present, whereas first two choice, small sign positive, no, you do not have a small sign positive, this is an exception. Prominent Y descent, no, you do not have a prominent Y descent. Okay, so that finishes your pericardial diseases. Let's move on one or two topics I want to discuss, and then we will go on to your valvular heart disease. Okay. Okay, let's start the topic. First of all, I would like to tell you different types of pulses that we have. We have already discussed few of them, but just in an organized way, we'll talk about the pulse, arterial pulse. This is very, very important. See, all pulses, when you palpate, the character of the pulse is best in carotid pulse, except for which two characters that you have to see the radial pulse. For which two characters radial pulse is better? For which two pulse radial is better? That is Bispherians and pulsus paradoxus. For these two pulses, radial pulse is better. Rest all characters are better elicitable in the carotid. Okay. Now let's move on. There is something known as bifid pulse. We already discussed. Bifid means two peaks in the pulse. Now we divide the bifid pulse into two parts. Number one, that means two systolic peaks, or you can have one systolic and one diastolic peak. Yes or no? Still, both the cases will have two peaks. Okay. Two systolic peaks we have already discussed. One of them, which one we have discussed in HOCM, which has two systolic peaks. What is that? No, not bigeminy. Bigeminy is altogether different. I'll tell you what it is. Bigeminy. What is HOCM? Which pulse do you have in HOCM? Spike and dome pattern. Spike and dome pattern. Whereas in case of Bispherians, in case of Bispherians pulse, you have two systolic peaks again. So that is a Bispherians pulse seen in severe AR. Okay. And the choices that they generally give, one of the MCQ that came was that severe AR plus moderate AS, severe AS with moderate AR, mild AS with moderate AR. So out of all these choices, see, you always remember that Bispherians is only seen in severe AR, not in moderate AR. Okay, not in moderate AR. Never you see in moderate AR. Okay, it should be severe AR. AS can be mild, moderate, severe along with the AR. AS can be mild, moderate, severe along with the AR, but AR has to be severe. You are understood? So that is Bispherians pulse. Okay. Now when we talk about the one systole, one diastole, this is known as dicrotic pulse. Dicrotic pulse, it is seen in case of cardiomyopathy. See, cardiomyopathy, what do you mean by cardiomyopathy? We have already discussed restrictive cardiomyopathy, we have already discussed hypertrophic cardiomyopathy. Out of these two, other than these two, the cardiomyopathy in general means that there is some disease of the cardiac muscle. Pathy means disease and cardiomyo means cardiac muscle. So what will happen to the cardiac muscle disease? What will happen? That means LV dysfunction. So cardiomyopathy in general is the term used for LV dysfunction. LV dysfunction. So wherever you see cardiomyopathy, it is LV dysfunction they mean. Okay. So LV dysfunction in young individual, you will have dicrotic pulse. Okay. Okay. So that is all about the bifid pulse. See, Bispherians pulse, you will see either it should be alone severe AR or severe AR with any severity of AS, mild, moderate, severe, whatever AS may be there. So it has to be severe AR alone or plus any severity of AS. Okay, but severe AR has to be there. Okay, now let's go on further after the bifid pulse. The next important pulse is that you get confused is the bigeminy and what is the pulses alternans. Okay, let me explain you. Okay, see, whenever you have a pulse, just keep in mind your ECG also. There are two things, one is your ECG, one is your pulse. Okay, in a normal individual you have a normal ECG. Okay, and the patient has a normal pulse. Correspondingly, you have a normal pulse. Okay, this is a normal scenario. Okay, now let me tell you different terms in terms of these two things. You will easily understand. Electrical alternance, when I say we did in cardiac tamponade, yes or no? Electrical alternance, what does mean electrical alternance? Electrical alternance means that ECG will change, pulse will remain the same. Pulse remains the same. So ECG changes occurs, electrical changes occurs, but pulse is the same. So what happens in electrical alternance? You will have R QRS amplitude varying. Okay, so R wave amplitude varies alternatively. So that is why it is known as electrical alternance. See, one R wave is tall, one R wave is tall, one R wave is short. So that means again tall, again short. So this is electrical alternance. Corresponding pulse, what would be the pulse in this condition? Pulse would be normal. Pulse is not varying. Okay, pulse is normal. So this is electrical alternance. Now I introduce a term what is known as pulsar's alternance. What is pulsar's alternance? Pulsar's alternance means pulse will change and ECG is the normal ECG. So what is it? Let's see. Pulse ECG first, let me draw ECG. ECG is normal. So you have a normal ECG. Whereas pulse, what is happening to the pulse? Pulse is alternatively varying in amplitude. Okay, this is known as pulsar's alternance. So you have understood the terms electrical alternance, pulsar's alternance. Okay, so what is happening? Pulsar's alternance, pulse is varying in amplitude, first tall, then weak, tall and weak. Okay, and now what is the cause of this thing? Severe LV dysfunction. Severe LV dysfunction is the cause for pulsar's alternance. Okay, you have understood. Now I introduce the third type of pulse. Third type of pulse is pulsus bigemini. So what is that? Pulsus bigemini. What is happening in pulsus bigemini? Yes, yesterday we did not talk about VPCs or APCs because of the so much of disturbance was there, and so let me tell you what is VPC. See, ventricular premature complex. What does it mean, ventricular premature complex? When I come to VT and SVT, I'll discuss in detail about pulses, that is ventricular premature complex. But you just remember, in pulses bigemini, both ECG and pulse will vary. Both are abnormal. Both ECG and pulse are abnormal. Okay. So what happens? What is the ECG? ECG will look like, I am drawing the ECG. Just see how the ECG looks like. ECG, you have a normal pulse and then a premature beat, and then a premature beat. Okay, and then there is a pause, long pause, and then a normal beat, followed by again a premature beat. So this keeps repeating, then there is a pause. So this keeps repeating. This is your ECG. And what is your pulse in this pulses by Gemini? You are drawing the diagrams, no? You should draw the diagrams because you will forget all this thing otherwise. So you will have one pulse, strong pulse, and one small pulse. Then there will be a pause. Again, one large pulse and one small pulse. Okay, so this will keep on repeating itself. So this is your pulses by Gemini. By Gemini means two pulses are coming in pair. Okay, so just I tell you again, revise it again for you. See, this is a normal individual with the ECG and a pulse which is normal. Okay, so okay, so I'll just tell you this is the normal ECG and uh, normal ECG and normal pulse. Okay, both ECG and pulse are normal. Electrical alternance, as the name suggests, only ECG will be different. That is, alternatively, R wave will keep on changing in amplitude, whereas pulse is normal. Okay, whereas pulses alternance, you have ECG to be normal, whereas what about pulse? Pulse changes alternatively. Okay, strong and weak, strong and weak. Whereas pulses by Gemini, when we say both ECG and pulse are abnormal, ECG also has a by Gemini pair of, one is a normal sinus beat, the other is your VPC. One is a pair normal sinus beat, other is a VPC. Just write down VPC. I'll tell you just now what is VPC. So you have one large pulse which is a normal sinus pulse, one small pulse which will be a VPC pulse. Okay. Yeah, both the pulses are in systole. Both are different QRS complexes. Both are different QRS complexes. One is giving rise to one pulse in bigemini, the other is giving rise to the other pulse. Okay, both are different complexes. So both are different cardiac cycles. Okay, bigemini is nothing but you have repeatedly coming VPCs. Yesterday we did digoxin. You remember digoxin toxicity, which is the most common arrhythmia that you see in digoxin toxicity. Yes. Which is the most common arrhythmia you see in digoxin toxicity? VPC. If VPCs come regularly like this, one sinus, one VPC, one sinus, one VPC, that we call as bigemini. So bigemini cause, one of the cause can be digoxin toxicity. Okay. So you have understood now. Okay. So there should be no confusion regarding the pulse. Let me discuss about the VPC, as we are discussing already about VPC and APC. So I'll just discuss about the VPC now. Okay. See, you should remember that, okay, let's go. I take a person whose heart rate is, let's suppose, 60 beats per minute. That means an individual with heart rate of 60 beats per minute, that means one beat comes in 1 minute. So that means one beat comes in 1 minute. 1 minute. 1 minute means how many seconds? Sorry, so 60 beats per minute means one beat per second. Yes, 1 second, one beat in 1 second. So one beat in 1 second means 1000 millisecond. Okay. It's one and the same thing. 1 second is equal to 1000 millisecond. Okay, we'll generally talk about cardiac cycle in milliseconds because it is very short duration. Okay. So if the sinus node, it has depolarized at point A, let's suppose it has depolarized at point A. After again 1 second or 1000 millisecond, it will again depolarize at point B. Yes or no? This is a normal sinus beat going on at 60 beats per minute. Understood? So now, if so, what is the sinus beat? Sinus is sinus node starting, AV node, bundle of phase, right bundle and left bundle. This is all your sinus. Okay. Now, if your beat comes early than the sinus beat, that means if you get a beat at 800 millisecond or 700 millisecond, let's suppose. So this beat is, what is this beat? This is a premature beat. Yes or no? This is a premature beat, and this is not a normal sinus beat. This is a premature beat. If it originates in the atria, it will be known as atrial premature complex. If it starts in ventricle, it is known as ventricle premature complex. Understood? Now let's see what would be the features of the two. Okay. Now further, if this beat, single beat, APC or VPC, whatever, single premature beat comes and after that the normal sinus rhythm continues, then we call it as a single complex. Okay, but if this premature beat continues means now it has come at 700 millisecond, now it comes rapidly, this premature beat is going on, it is not letting the sinus beat to come, it is the premature beat that is going on continuously. So what it becomes? APC is nothing, it will become SVT, and if VPC continues, it is nothing but VT. Okay, so you have understood. Single extra beat comes prematurely, we call it as a complex, one complex, one complex. But if continuously it comes, continuously, it does not let the sinus beat come. So what it becomes? If it is starting in APC, if it continuously APCs are coming, then we will call it as supraventricular tachycardia. If the VPCs are coming continuously, we will call it as ventricular tachycardia. So whatever difference is there between APC and VPC is the same difference between SVT and VT. Okay, so MCQ, if they ask you about APC versus VPC or SVT versus VT, the answer remains the same. Okay, so let's talk about the differences. Divide your page. This is SVT, this is your VT, and this is the common features. Understood? SVT, you can say it is an APC, or VT means VPC. Okay, so let's see. In a normal individual, your sinus beat starts over here. Okay, and the wave of depolarization reaches the ventricle through the bundle of phase, and the two ventricles simultaneously get depolarized. Yes or no? Any confusion? So what is, in a normal individual, what is the AV relationship? Sequential or simultaneous? We did it earlier also. Sequential or simultaneous? AV relationship in a normal individual. Sequential. What is the VV relationship? VV means RV and LV relationship. RV and LV. It is simultaneous. Okay, just remember this much. Okay, now let's talk about APC. What happens in APC? APC means premature complex originating in the atria. So this is the premature complex originating. Now it will start depolarizing. So when it starts depolarizing the atria, okay, this wave of depolarization will reach the AV node also. This will go through the bundle of phase, then again go to the ventricle. Just like a normal beat, it will go to the ventricle. Yes or no? So now you tell me, in an APC or in an SVT, what is the AV relationship? What is the AV relationship? Yes, in SVT the AV relationship is sequential. Why simultaneously you are writing? It is sequential. Okay, just like a normal. It's not simultaneous. AV relationship we are talking about. And what about VV relationship? What is the VV relationship in APC? Just like normal, it is simultaneous. You are understanding the concept. See, the only difference from the sinus beat is that this APC is starting somewhere different point in the atria, not from the sinus node. So what will it happen? It will go and down through the AV node. Because it is going through AV node and bundle of phase, the relation between atria and ventricle will remain the same as your sinus beat. So you have sequential and VV relationship would be both will get depolarized simultaneously. So VV is simultaneous. Okay, so that is understood. Now you tell me, AV dissociation. Will there be AV dissociation in case of SVT? Will there be any AV dissociation in SVT? So you all agree that there will be no AV dissociation. So SVT will not have AV dissociation. Number fourth point. So if there is no AV dissociation, will you have Cannon wave? Will you have Cannon wave? You will have no Cannon wave. Okay. What would be your QRS? What would be your QRS? QRS would be the same as sinus QRS, or it would be a different broad QRS? It will be same as normal narrow QRS, or it would be your broad QRS? Same as sinus. So normal narrow QRS. So it is the same normal and narrow QRS. Okay. So let's move on further. Now let me draw the VT part. Let me draw the VT part. So again in this diagram I'll show this is your sinus node, AV node, bundle of phase, right bundle and left bundle. Now over here let me explain you what is VT. So what is happening is one of the focus in the ventricle starts to produce your premature beat, or it starts to produce your depolarization. Yes. So this depolarization, it will spread in the ventricle. First it will depolarize the left ventricle, and then it will go on to the right ventricle and depolarize the right ventricle. Yes or no? Right. So you have a wave of depolarization in VPC starting in one of the ventricle. I have taken it to be left ventricle. So it goes into the right ventricle. So what is the first of all, what is the VV relationship in the VPC? Tell me VV relationship in VPC. It is sequential. So you write down it is sequential in case of VT. Okay, sequential. Now see, what do you think the spread of depolarization wave within the ventricle, is it fast or is it slow? This VPC, when it is spreads to depolarize the ventricle, will it be slow or fast? So Merit says it is fast. Why do you say it is fast? See, you have a specialized conduction tissue, that is your bundle branches. This is your specialized conduction tissue. If you are not going in the direction of specialized conduction tissue, you are going now in the opposite direction. It's just like expressway. You are moving in the opposite direction on the expressway. So what will happen? If you are moving in the opposite direction in the expressway, your speed will be less, not fast. Right? So the spread speed would be slow. So it would be spreading very slowly. You are understanding the point? Okay. So now let's move on further. So this is how it is spreading. So this will spread very, very slowly. Plus the two ventricles will be sequentially depolarized. So what do you think would be your QRS? It will be narrow QRS or it would be a broad QRS? It will be a broad QRS. So you all agree that this will be a broad QRS. Yes. So this is another feature of the VPC, wide and broad QRS. Now what happens is, see, what happens is, now let's suppose the VT, this VT that originates from the ventricle, the rate of VT is 200 beats per minute. 200 beats per minute. Yes, it is the rate of your VT. Okay. Now you have a sinus node Sinus node is normal, yes or no? So sinus node, your rate is 60 beats per minute. So now what will happen? You will have ventricular depolarization coming from your VT focus. And from where would your atrial depolarization come? Atrial depolarization will come from your sinus node, which is at the rate of 60 beats per minute. It's just like complete heart block, but there is no block, mind you. I am just saying it is like complete heart block, where what is happening in complete heart block? Atrial rate is 60 is more, whereas in complete heart block your ventricle rate is less. But opposite to that over here, what is happening? Atrial rate is less, 60, whereas ventricular rate is 200. Okay, so this will result in, yes, Aligarh is absolutely right, and Vijayawada also, that this will result in AV dissociation. That is my point of telling you. Okay, so VT, VPC, whatever you may call it, you will have AV dissociation. Okay, so AV dissociation, yes or no? Yes in VT. And Cannon wave, yes in case of your VT. Okay, so that is very clear to you. Now you tell me, if atria is getting depolarized from your sinus node and V ventricle is getting depolarized from your uh, different focus within the ventricle, so that means what is the AV relationship? What is the AV relationship? What is the AV relationship? Yes. See, there is no relation, but what do you mean by relationship? Means that when the ventricle is contracting or when the atria is contracting, there is a chance that the two may contract simultaneously. Yes or no? Because both are at their independent rate, just like complete heart block. So you have different rates. So the two may contract simultaneously at a particular point. Okay, it can never be sequential. Sequential means when one leads to the other. So it is never sequential. Okay, so it can be either simultaneous. So you call it as simultaneous. You can call it as simultaneous, or you can say, okay, you can call it also, you can call it as no relationship. That is also okay, but it can be either simultaneous or no relationship. Okay, but it can never be sequential. You are getting my point. So your AV VV relationship, AV dissociation, Cannon wave, QRS, you all have understood. Now you tell me one more thing. When you have two waves of depolarization, so that means fusion beat. Fusion beat occurs when you have two waves of depolarization. Where do you have two waves of depolarization? Where do you have two waves of depolarization? VT or SVT? No, not WPW. Don't go on to WPW. WPW is a different scenario. Within the APC and VPC, you tell me. Where do you have two waves of depolarization? See, it is the VT. Agartala, why you say SVT? SVT it cannot be. Why? Because if you see the SVT, what has happened in the SVT? There was one wave of depolarization only that was going down from, there was only one wave. This was the only focus that was giving rise to your SVT. Okay, whereas sinus node will not discharge. Na? Once your this focus is discharging, sinus node will not discharge. Okay, so you will have only one wave of depolarization. Whereas when you have wave of depolarization in the ventricle separate, then sinus node will discharge. So the two will result in two waves of depolarization. So your fusion beat will be a feature of which tachycardia, VT or SVT? It will be a feature of VT, not of SVT. Okay. Ventricle beat can go to atria. I have not said it cannot go to atria, but before the time, before it reaches the atria, it is so slow. Before it reaches the atria, what happens is sinus node beat comes of its own. So by the time it reaches, sinus beat itself gives the beat. So that results in two waves of depolarization. You are understanding the point, right? Okay, let's move on further. Another point. that I want to tell you. One thing is sinus node resetting. Sinus node resetting means, that means sinus node resetting means, what does sinus node resetting? That means the abnormal wave of depolarization, is it affecting the sinus node or not? So in which condition it is affecting the sinus node? In which condition sinus node is getting depolarized by the abnormal wave of depolarization? So there is a mixed response. See, it has to be SVT. Why you say VT? You have not, that means, understood the thing. See, sinus node resetting means, that means the wave of depolarization goes to sinus node. So where is the wave of depolarization? In the SVT, wave of depolarization, abnormal wave starts within the atria. So it will definitely go to sinus node. It will spread and go to sinus node. It is close by. Yes or no? Whereas in VT, I told you VT, by the time it goes to sinus node, it is so slow it cannot reach the sinus node. Before that, sinus node discharges its depolarization. Yes or no? So that means VT wave of depolarization does not reach the sinus node. Whereas in APC or in SVT, it reaches the sinus node. Okay, so many of you have understood, but those who have not understood, now you have understood. Okay, so let's move on. Sinus node resetting you will see in SVT, not in case of VT. So these are the technical terms. Actually, MCQ comes with the choices of sinus node resetting, fusion beat. So I have to use those terms to tell you. Okay. Now let's move on further. What is the further point? There are two C's which will be seen only in case of VT. What are these two C's? Capture beat. One is capture beat and the other is your compensatory gap. So these two things, capture beat and compensatory gap, they are seen only in VT. I won't explain you the mechanism, that is not required. Just understand that it is visible only in case of it is visible, or it is seen only in case of VT. Okay. So okay, so let's move on further. So you have understood the compensatory gap, you have understood the capture beat, and now let me again, there are few points more difference between SVT and VT. Now when I tell you that palpitation, I told you the palpitation in any arrhythmia, it occurs because of the fast beating of which chamber, atria or ventricle? It is the ventricle, that you have all understood. Okay, so if I say, if I have to manage palpitation with the AV nodal blocking drug, I have to reduce the ventricular rate by using AV nodal blocking drug. Now you tell me in which arrhythmia, SVT versus VT, that I will be able to reduce the ventricular rate by giving AV nodal blocking drugs. You are absolutely right, SVT. That is why in atrial fibrillation, in atrial flutter, they all are SVTs, and their AV nodal blocking drugs will reduce the ventricular rate. Whereas in case of ventricular tachycardia, because it is starting within the ventricle, it is not going through the AV node, you cannot reduce the ventricular rate by giving AV nodal blocking drugs. Okay, next point. If you have to reduce the ventricular rate by increasing the parasympathetic supply, in which arrhythmia you will be able to reduce the ventricular rate by increasing the parasympathetic supply? So that means few are saying VT. See, I give you another I give you a clue. Clue is that parasympathetic sympathetic supply. Yeah, absolutely right. There is no parasympathetic supply to ventricles. It's only available to atria and AV node. So now you tell me There is no supply to ventricle, so parasympathetic supply, if you increase, it will control the ventricular rate only in case of SVT. So how do you increase the parasympathetic supply? Carotid sinus massage. So carotid sinus massage is the one thing that is given in case of your SVT. Okay. Now let's move on further. PSVT we have discussed. See, in case of PSVT, I tell you simple thing. PSVT is just like, not like SVT. There are many features similar to SVT, but the important thing is it is just like junctional tachycardia. You think of junctional tachycardia, it is like a junctional tachycardia. Okay, so we have already discussed the junctional tachycardia. What happens in case of junctional tachycardia? There is a node, from there the wave of depolarization goes above and goes down. Okay, so the A and V occur simultaneously. So you will have Cannon wave, but you will not have AV dissociation. That is the important point in PSVT. So PSVT, it's just like junctional tachycardia. Okay, just behaves like junctional tachycardia. So just I'm asking you out of this thing, what do you think would be the QRS in case of PSVT or junctional tachycardia? Broad or narrow? Narrow, absolutely right. So that means you have all understood the concept. So PSVT will also have a narrow complex, but the only thing is that because atria and ventricle, what is the relationship? It is simultaneously happening. So the two will result in simultaneous depolarization, and you will have Cannon wave. This we call as Cannon wave. This will not be your AV dissociation. So you have a Cannon wave without AV dissociation in PSVT. Okay, so that I finish this topic of SVT versus VT. So any doubt in this? Let's move on further. We have very little time. Let's move on further. So physical I have almost covered. So there is nothing much is left in case of this thing. So okay, valvular heart disease. Valvular heart disease, that is, there is no specific valvular heart disease, is very simple. Just I'll highlight what is important points that are asked in the exam. Okay, valvular heart disease you will all do in detail regarding in your this thing. Final year you must have done it, so most of you know your valvular heart diseases. So the only important points I will highlight, that is number one is your management. So let's talk about the regurgitant lesion. See, I draw a pressure volume curve that you already have learned in your physiology. So what is the pressure volume curve in case of your okay, this is your pressure volume curve, normal pressure volume curve, that is we have. Okay, so now let's talk about the abnormal pressure volume curve. Let me draw the abnormal pressure volume curve. Okay, now you tell me, what is this abnormal pressure volume curve denotes? Which condition? Regurgitation, stenosis, or dysfunction? This denotes what? Why not dysfunction? Regurgitation you all are saying, why? Because your volume increases. So volume will increase also in case of dysfunction. I told you, whenever dysfunction is there, that cavity dilates. Yes or no? So that cavity dilates, so that will happen even in case of LV dysfunction. right? So that means some other factor has to be taken into account. So let me tell you. Okay, very simply I'll tell you. See, what happens is, this is your end diastolic, this is your end diastolic volume, this is your diastole happening, and this is your end diastolic volume. And after the systole, this is the systole volume is reducing. So this is your volume part, this is your pressure part, and the end of the systole, whatever volume is left, this is known as end systolic volume. Yes or no? So now what is your EF? Ejection fraction equal to end diastolic volume minus end systolic volume divided by end diastolic volume. Yes or no? So this is your ejection fraction. Now, in case of regurgitation lesion, your end diastolic volume increases. So this increases. There is no doubt about it. So this will also increase in your dysfunction. LV dysfunction, RV dysfunction, I told you, both gets dilated. So this will happen even in case of your dysfunction also. So both gets dilated. So that means this is, how do you differentiate between regurgitation and dysfunction then? In case of regurgitation, ejection fraction is normal, or in fact it is increased. So what is happening? See, from this much end diastolic volume, heart contracts and brings its volume back to the normal end systolic volume. So that means contractility of the heart is increased now. From so much dilatation, it is coming back to its normal volume after the systole. So that means this systole is resulting in increased contractility. So that means it is not dysfunction. So what will happen in case of dysfunction then? In case of dysfunction, from this end diastolic volume, end systolic volume would be this much. So the curve would end over here, and this would be your curve for LV dysfunction. So what is the difference between the regurgitant and your LV dysfunction curves? The difference is of the end systolic volume. So the moment end systolic volume increases, that means it is LV dysfunction. You have understood? Okay. So let's move on further. What is the management of MR and AR? Let me tell you the management of MR and AR, which is very, very important. See, what you have not understood. The simple thing is that from the large end diastolic volume, your heart is contracting and bringing it back to a very normal end systolic volume. That means this much of blood it has pushed out. So that shows its contractility. Yes or no? So whereas in case of LV dysfunction, what will happen? From this end diastolic volume, it will come and stop here, because its contractility is less. It can only push this much blood. So this much blood will remain inside the cavity. So that means end systolic volume will increase. You can see me now. That is how I am describing you with my hands. So if you can see me, then you must have understood it. From the large volume, if you are able to bring it back to the normal end systolic volume, your ejection fraction is more. Okay, when you are bringing it from large volume, LV is able to bring it only up to this point. That means it is LV dysfunction. Okay. So LV dysfunction means it is a decreased LV function. Okay. So now let's move on further, the management of AR and MR. Okay, let's talk about the management of AR and MR. End systolic volume will increase in case of dysfunction, because LV cannot contract and cannot push the entire blood, so it will remain dilated. So end systolic volume will be high in case of dysfunction. In regurgitation, because LV is normal, So what will happen is, from large diastolic volume, it will bring back to its normal systolic volume. That means it will push the entire blood out. So that means it will get empty and resulting in low end systolic volume. Okay. So now let's move on further. The management remains the same for MR and AR. What is the management? MR and AR, what is the management? MR and AR, see, you only manage severe symptomatic individuals. Severe individual, first of all, it should be severe. You just write down here severe. Then you see for the symptoms. If the patient is symptomatic, you will operate and valve replacement is to be done. Now, if the patient is not symptomatic, he is asymptomatic. Asymptomatic. Now, what is happening? If a patient is asymptomatic, now you have to look for the LV dysfunction. How do you look for LV dysfunction in this individual? That means EF is reduced, decrease EF, or which volume will increase? That will be suggestive of LV dysfunction. Which volume will increase will be suggestive of yes, end systolic volume. You are all right. So if end systolic volume increases, then again it will be suggestive of LV dysfunction. So that means these two kind of individuals you have to do valve replacement. But asymptomatic individual, no LV dysfunction, no LV dysfunction. What is the management? You just have to do echo, 2D echo regularly. Regular follow-up. Regular follow-up is the management. Okay. Regular follow-up is the management. Okay, let's move on. That is all about the management of MR and AR. See, MR and AR. So MR and AR, everything, the management is almost the same. Okay, now let's talk about AS and MS. That is very, very important. MS and AS. There are different cutoffs, but I don't think you need to know. Okay. So see, I can understand that those who are from foundation batch, they have not done their valvular heart disease. But see, the point is that I cannot cover entire syllabus in these 2 days. Okay, so you just cannot expect me to cover up the entire course. This cardiology is not a small subject, so we have to cover only those parts which are important from MCQ point of view. This specifically, this coaching is to make you, I personally feel that this is to make you understand the concepts. In valvular heart disease, there is not much concept that you have to understand. Okay, whatever was there, pericardial diseases, VT, SVT, all these I have told you. I have given you given you in detail all the concepts. Why? Because they are important to understand. Infective endocarditis, acute rheumatic fever, they will be given in your all MCQ books. So you just have to go through that, and that is all theory. There is nothing to teach you, nothing to make you understand. Okay. That is why I only deal with those subjects, all those topics which requires understanding. Okay, they will not be given. PCWP again will not be given anywhere. So that is why I don't skip that. Okay, so just do your homework also. That will be sufficient. Let's finish off our class with MS and AS. Okay, let's talk about MS. See, mitral stenosis, when I say mitral stenosis, what is mitral stenosis? The normal valve area, what is the normal valve area of mitral valve? 4 to 6 centimeter square. Okay. And what is the normal valve area of aortic valve? Aortic stenosis, what is normal valve area? 3 to 4 centimeter square. And when do you call stenosis? Stenosis you call in mitral valve, you call it when the area decreases less than 2 centimeter square. Similarly in aortic valve also less than 2 centimeter square. Okay, so this is when you call it as stenosis. So what is there in between 4 to 2? What is there in between? I told you again and again that God has given us lot of reservoirs. See, your one kidney is enough, but God has given you two kidneys. Similarly, for heart, God cannot give you two hearts. Yes or no? Huh? God knows that you cannot take care of one heart. What will happen if He gives you two heart? Huh? So nothing will be happening in the on the earth. Huh? So that is why He has given you one heart, but there is a reservoir within the heart that is like valve area. Valve area He gives you twice or thrice that much what is required. So He has given you 6 centimeters square, but the requirement is just of 2 centimeters square. Below 2 centimeters square, your filling gets impaired. So that is why we call it as stenosis below 2 centimeters square. Okay, now let's move on further. What is there less than 2 and less than, okay, let's move on further. The mild, moderate, severe MS. How do we classify mild, moderate, severe MS and mild, moderate, severe aortic stenosis? Mild, moderate, severe MS is 1.5 to 2 centimeter square surface area, 1 to 1.5 centimeter square, less than 1 centimeter square. Same applies for aortic valve. So it's the same classification, mild, moderate, severe. As the area decreases, severity increases. Okay, what is the management? That is the most important aspect. See, in mitral stenosis, the management is when the patient is symptomatic. Why the patient is symptomatic in mitral stenosis? You just tell me. Why patient is symptomatic in mitral stenosis? Because there is a problem in filling. There is a problem in the filling, and that results in your increase in the LA pressure, and LA pressure results in increased your PCWP, and you have pulmonary edema. Yeah, you are all right. So that means filling is the problem, diastolic filling. So diastolic filling you can increase the diastolic filling by number 1. How can you increase diastolic filling? Number 1, increase the diastolic period. Increase diastolic period, duration. So bradycardia, absolutely right. Srinagar is absolutely right. Bradycardia. Okay. If the patient is still symptomatic, even after bradycardia, patient is symptomatic. So what do? Now you have to increase the mitral valve area. Okay. So how do you increase the mitral valve area? See, how do you increase mitral valve area? For that, you have to see 2 points, very important points. That is, whether there is any thrombus present in the left atrium. LA thrombus is present or not. If there is an LA thrombus present, then what will happen is that what we do is BMV, balloon mitral valvotomy. This cannot be done if there is an LA thrombus present. Again, I remind you that whatever procedure we do under fluoroscopy. So under fluoroscopy, can you see a clot in the LA? On X-ray, can you see a clot in the LA? So you cannot see a clot in LA. So what will happen? If I try to do BMV, balloon mitral valvotomy, how do I do balloon mitral valvotomy? I go from, see, the very simple thing, I go from IVC, from the IVC I go into RA, then across the interatrial septum I go into LA, and from the LA I go into LV, and across the mitral valve I put my balloon and inflate the balloon. This is how I do balloon mitral valvotomy. The term itself, balloon mitral valvotomy. Okay, just like PTCA, just like PCI we did on wire, we'll put a balloon in the coronary artery and dilate the balloon. Similarly, we'll put a wire across the mitral valve and take a balloon over the wire into the mitral valve and dilate it. Okay, so when you are taking the wire, you are taking the balloon into the mitral valve. See, if there is any clot in the LA, what will happen to the clot in the LA? If there is a clot in the LA and I try to do BMV, what will happen? Stroke can happen. It can embolize and can result in stroke. Yes. So that is the risk. That is why you will not do BMV if there is an LA thrombus present. Okay. So what you can, if there is no LA thrombus, you will do BMV. So the management of choice is BMV. Management of choice is BMV. If there is no thrombus, if there is a thrombus present, then it will cause, then there is no BMV. Then what is the option if there is a thrombus present? Open mitral commissurotomy. This we call as open mitral commissurotomy. Open mitral commissurotomy, it is done by surgeons. They open the heart, they open the RA, they open the LA, see the clot, take out the clot, and then they open the mitral wall. Okay, so that is open mitral commissurotomy. That is all about the management of mitral stenosis. That's all. Now let's talk about the management of, see, you are asking me whether it can cause ASD when we do the septal, we go across the septum, we go through PFO. What is PFO? What is PFO? Yes, what is PFO? Patent foramen ovale. Yes, so we go through patent foramen ovale, so that is why it there is no scope of ASD. Okay, now how do you know? We yesterday did LA thrombus presence. How do we know whether there is LA thrombus present or not? Yes, how do we do? Echo, yes, you are absolutely right. 2D echo, and what type of echo you will do? Transthoracic or transesophageal? So simple. So you have to do the transesophageal echocardiography. Okay, and if see, valve replacement is the last thing. If you cannot do the open mitral commissurotomy, valve is very bad, you go for valve replacement. There is nothing in that. Okay. Okay. Yeah, you are right. Fossa ovalis is there in adults only. Okay, let's move on further. The management of aortic stenosis. What is the management of aortic stenosis? It is the severe aortic stenosis that you will manage. And how do you manage severe aortic stenosis? Once the patient is symptomatic, okay, you have to do aortic valve replacement. Okay, or if the patient is asymptomatic, again the same thing, but there is additional point in this. Okay, if the patient is asymptomatic, now you have to look for ejection fraction again, just like MR and AR. If ejection fraction is less, if it is less, if it is LV dysfunction is present, you will go for AVR, aortic valve replacement. If ejection fraction is normal, now what you will do? Ejection fraction is normal. What do we do in case of ejection fraction normal? See, in case of ejection fraction normal, there was a guideline, change in guideline in 2010, that was that a patient who is aortic stenosis asymptomatic with normal ejection fraction, you have to do the TMT to see his exercise capacity. If the exercise capacity is poor exercise capacity, then you will go for aortic valve replacement. AVR means aortic valve replacement. And if exercise capacity is good exercise capacity, that means you will go for what? You will go for follow up, echo follow up. And another MCQ that comes is that which drug is not given in aortic stenosis? See, all vasodilators you will not give in aortic stenosis. So specifically the choice they ask is the ACE inhibitor. ACE inhibitor is a vasodilator that you will not give in your aortic stenosis, severe aortic stenosis. Okay, so yes, so that finishes our valvular heart disease also. And I think I have made many topics to you understand the basics of many topics. So, okay, this is your entire management of aortic stenosis. Okay. Okay. So there is nothing much in case of murmurs, infective endocarditis, as well as your rheumatic fever. You read any of your MCQ book that you will get about your this thing. You will get the theory and you just read it. There is nothing much in there. Okay. And as far as the foundation batch is concerned, I would like to tell you one thing that see, try to build your concepts. That is very, very important. Okay. And if you have the concept, then you will be able to answer your all your questions. And those who are going for your entrance exam this year, let me tell you, do as many MCQs as possible and make your notes. Make your notes. That is very, very important. Okay. If you make your notes, then you can revise them again and again, and it will not take much time to revise it. But if you keep them scattered in different books, it will take lot of time to revise when you have to revise them. Okay. So I think I have discussed all the important topics whatever required the consideration. And if you want any book you can follow, just follow my notes and you keep adding to it your extra points, so that will compile your complete cardiology notes. Okay. So and see, murmurs and S3 S4, it's one and the same thing. It is given in your any of your standard MCQ book. You can go through it. Okay. So and you have my MCQ, you have my email address. If there is any specific problem you want to ask me, you are most welcome. I again give you my email address. Okay. So those who have any problem while solving any of the MCQ, they can contact me on my email address. Okay. Thank you everybody. Okay.